just want to get. Mhm. Mhm. Okay. All right. So I think we are going to go ahead and get started. Thank you, everyone, for joining us here today. This is our Stanford Healthcare Pituitary Patient Education Day. We're so excited to have you come both here in person, as well as the many hundreds of folks who are joining us today by Zoom as well online. So every few years, we try to have this Patient Education Day for you. To learn more about your condition, for you to learn a little bit more about maybe things that you don't always have the time or forget to ask during your clinic visits, those 10 to 20 minutes that can be so precious. And also, this is an opportunity for you to meet folks who are maybe in similar situations, who are also sharing the same condition, maybe in the same boat as you, and to make those connections and relationships. So we have a great program here today, representing from neuroendocrinology as well as neurosurgery with Dr. Fernandez-Miranda. And we also have representatives from radiation oncology and ENT. And then most excitingly, I think, is our pituitary community leaders who are here with us today. So we have Leslie Edwin from the Cushings Support and Research Foundation, Jill Sisko from the acromegaly community, as well as Catherine Jonas from CJ Care Associates and Consulting. And so these are patient advocate groups that really work for you on your behalf. And we're so excited to have them come here and share their wisdom and perspectives with us. I'd also like to just acknowledge our event sponsors, Camarus and Ricordati, for their support of this event. And we thank you very much for your support. I just want to introduce again our Pituitary Center team leader. So I'm Julia Chang. I'm the medical director of the Pituitary Center, and I represent neuroendocrinology. And of course, Juan Fernandez-Miranda, our surgical director. Leslie Edwin, Catherine Jonas, and Jill Sisko will be speaking later in the morning, as well as members of our team, Noel Ayoub from otolaryngology, Robert Dodd, neurosurgery, and Elham from radiation oncology. And then other members of our neuroendocrinology team, Susan Seav and Andrew Hoffman. Our nurse practitioners, who you probably interact with quite a bit online and on phone calls, Olivia Chu in neuroendocrinology and Erin Wipff. But outside of this team, and we have many members, so ophthalmology, our eye specialists, our radiology specialists as well, amongst many more. So I'd like to kind of end with this quote. Working as a team is key in surgery. Each of us has become super specialized in our own area, the eye, the nose, the base of the skull, endocrinology. But we all come together to provide the best for the patient. And then so each of you should have a flyer with the agenda listed here. And so the first half of the morning is going to be just an overview of pituitary tumors. You'll hear a little bit about the endocrine side of things, medications, innovations in surgery, radiation treatment. And then we'll take a short break, and then we'll have our pituitary community leaders speak as well. And then we'll break for lunch at around 12:45, but we'd like to do a group photo right beforehand. So if you have signed the waiver, we'd love to have you join us in the photo. And then after lunch, in the afternoon, we have breakout sessions. So one of the breakout sessions will be management following pituitary surgery and what to expect. And then a concurrent breakout session, and the other half of the room will be on Cushing's support and research foundation, where you can get more questions answered and hear more from the community. And then we'll have a set of breakout sessions following that, again with management following surgery, and then hearing from the acromegaly community leaders. And then we'll end the day with a general Q&A. And this is just our agenda again. Okay, so I will go ahead and get started. Okay. All right, so we're going to go ahead and get started with just an overview of the pituitary tumors. So I'm a clinical assistant professor in the Division of Endocrinology, as well as the Department of Neurosurgery. So in today's session, we're going to just, get real basic of what is the pituitary, where is the pituitary. We'll discuss the different types of pituitary hormones, the different types of pituitary adenomas that you may see, and how they manifest in the body, the clinical symptoms, and then the treatment options for each. We'll spend a little bit of time talking about Rahimy cleft cyst and craniopharyngiomas. These are also not uncommon pituitary lesions that we see here in our clinic. And then end with endocrine hormone evaluation before and after pituitary surgery or with surveillance. So what is the pituitary? So this is a common question. You're come to our clinic and all of a sudden you've been diagnosed with something in the pituitary, but you've never even really heard what that term is before. So the pituitary gland is a small gland that sits at the base of the brain, the base of the skull. It's about the size of a large pea, about 1 centimeter. And it's connected to the rest of the brain and the central nervous system by a thin pituitary stalk here. And it's surrounded by very many important structures. So on either side, you have the carotid arteries that bring blood flow to the rest of the brain. And then importantly, running right above the pituitary, you have the optic tracts or the optic chiasm. And this is important because they control your vision. And particularly the optic chiasm classically regulates the vision for the peripheral field. So that outside quadrants of your vision. So you can imagine that, for a very small gland and very small space, if there's something large that starts to grow and starts to hit those important structures, that can cause problems and can cause headaches and then vision problems as well. But what does the pituitary do exactly? So the pituitary I always like to refer to as the master hormone gland. And so the pituitary is divided into 2 parts. There's the anterior or the front part, and then the posterior or the back part. And each of these lobes make different hormones. So the anterior lobe makes about 6 hormones, and we can go through each of these briefly. And so the first hormone here is growth hormone. And growth hormone acts on bones, muscles, and organs to grow, essentially. It acts on the liver to produce a hormone called IGF-1. You can imagine that in children, growth hormone is very important so that they can reach their adult body size. The anterior pituitary also makes a hormone called ACTH, and this stimulates adrenal glands to make a hormone called cortisol. Cortisol is a very important stress hormone. It's part of our fight or flight response, very important for blood pressure, for electrolytes, sodium balance, blood sugar. It really is the hormone that kind of helps us get up in the morning and get us going for the day. The anterior pituitary also makes TSH, or thyroid stimulating hormone. This acts on the thyroid gland to make thyroid hormone directly. And so the thyroid is very important for body homeostasis, regulation of temperature, of cardiac function, metabolism as well. The anterior pituitary makes FSH and LH. These are hormones that then act on the testes to make testosterone, and as well as the ovaries to make estrogen and control the menstrual period. And the anterior pituitary, lastly, makes prolactin, which is a hormone that's important for breastfeeding and milk production from the breast. In the back part of the pituitary, they make 2 different types of hormones. So there's ADH or AVP, antidiuretic hormone. And this is important for water balance and sodium balance. Without ADH or AVP, you would be urinating very, very frequently, watery urine, feeling very thirsty. And maybe some of you have experienced that here in this room. And then the posterior pituitary also makes a hormone called oxytocin, which is important for uterine contractions during childbirth, as well as part of the letdown response with milk production. So what are pituitary adenomas? And another term that you might start to come across more now is neuroendocrine tumor, NET. Sometimes you might see that in some of your pathology reports. But the emphasis that I want to make here is that pituitary adenomas are benign, non-cancerous growths of pituitary cells. And while they can grow large, they do most of the time, 99% of the time, they don't spread to other parts of the body and metastasize to other areas. Most pituitary adenomas are sporadic, meaning that it's not from an inheritable genetic mutation that you have received from family members or that you would pass on to other members of your family. So 95% of these are sporadic. And pituitary adenomas are actually not that uncommon. So based off of autopsy studies where they've looked at thousands of cadavers and looked at their pituitaries, we actually see that about 10% of those pituitaries have a pituitary adenoma or something in the pituitary, some type of pituitary lesion. But again, the vast majority, over 99% of those, are actually quite small, less than 1 centimeter. So even though pituitary adenomas are not that uncommon, the ones that come to clinical attention are more rare. So only about 1 in 1,000 or about 0.1% of the population actually then get referred and see us in endocrinology or neurosurgery for a pituitary lesion. And this might be because of symptoms that you may have, like headaches or changes in your visions, or symptoms from hormone disorders. But more commonly, actually, too, now we see that these pituitary lesions are picked up because of patients getting brain scans and head imaging for other reasons. So, for instance, maybe you went to the emergency room or went to your doctor because you were feeling a little bit dizzy or were experiencing hearing loss, and you had an MRI or a CT scan. And maybe it had nothing really to do with the pituitary, but lo and behold, there is a pituitary mass there, and that may buy you a referral into our center. And so we can classify pituitary adenomas based on their size. And so microadenomas are those that are less than 1 centimeter, usually contained within the pituitary themselves. And so you can see that on the schematic here, as well as an MRI. And then with macroadenomas, these refer to growths that are more than 1 centimeter, and these tend to be more invasive. And you can see that as these start to grow, and particularly they start to grow upward, it can put pressure on that optic chiasm, and one can start to have vision problems. And then for the large pituitary adenomas, quite large, maybe more than 4 centimeters, sometimes we refer to these as giant pituitary adenomas. And so this is actually an MRI scan of one of our patients who came to the hospital last year, was having headaches and vision problems, and was found to have this on his MRI. We can also divide and classify pituitary adenomas by their hormone status and what we call functional versus non-functional. So functional pituitary adenomas refer to those that secrete hormones in excess, over-secrete hormones, and they can cause a constellation of symptoms or a syndrome. And so the types of functional pituitary adenomas are here. So prolactinomas, so pituitary adenomas that make too much prolactin. Acromegaly, which is a condition where the pituitary adenomas make too much growth hormone and thereby making too much IGF-1 from the liver. In Cushing's disease, you have pituitary adenomas that make too much ACTH and tell the body to make too much cortisol. And then rarely, we also actually have TSH-omas as well, where the pituitary adenomas make too much TSH and thyroid hormone. Meanwhile, non-functional pituitary adenomas don't cause hormone excess, but they can cause mass effects. So they can cause those headaches or vision changes, especially as they grow larger. And they can also cause low pituitary hormone function, pituitary hormone deficiencies, a term that we call hypopituitarism. And that becomes more common as well as they grow larger. And when you actually look at the breakdown of all the different types of pituitary adenomas, you can actually see that more than half are prolactinomas, and then followed by non-functional pituitary adenomas comprise about 30% of lesions. And this is followed by growth hormone and acromegaly, 12%, and then Cushing's disease, ACTH-producing pituitary adenomas is 4%, and then other 1%. So how do we treat pituitary adenomas? So for most functional pituitary adenomas, surgery is the first line. So for those with acromegaly, for Cushing's disease, for those rare TSH-omas, but also for those larger non-functional tumors that are causing those vision problems, headaches, that might be invading local structures. For prolactinomas, however, we can usually start to treat these with medication first, and use that to control both the hormone as well as tumor size, which we'll get into in just a little bit. And then for smaller non-functional tumors that are not really causing any vision problems and folks are asymptomatic, not having any symptoms, these can just be followed by regular MRI scans and periodic hormone testing. So let's talk a little bit about each of these pituitary tumors and pituitary adenomas. So prolactinomas, so as I mentioned, pituitary tumors that oversecrete prolactin. These will act on the mammary gland and breast tissue and can cause milk production from the breast. And so this milky nipple discharge. And so folks might come in and say that they've noticed some stains on their shirt or even their bra, and wondering what that's from. Prolactin can also decrease the sex hormones, and so testosterone and estradiol or estrogen. And this can lead to changes in menstrual function, can lead to loss of menses altogether in some cases, as well as erectile dysfunction in men. And in both men and women, this can lead to low libido or low sex drive, as well as fertility problems. And as I mentioned, we generally treat prolactinomas first with medication. So cabergoline and bromocriptine are the two most common medications for prolactinoma. Cabergoline we use generally more. And these can be quite effective. So cabergoline can really substantially reduce prolactin and result in a tumor size in up to 90%, decrease of tumor size in up to 90% of patients. Bromocriptine is also quite effective, but maybe slightly less so, maybe about 70% of patients. And it can also be associated with more side effects. So for that reason, we usually start with cabergoline. But for some folks, they still have side effects with these medications and are not able to tolerate them, or the prolactin doesn't respond fully, or the tumor is not shrinking. And in those cases, we would refer to surgery. And now actually surgery is becoming a more popular option too for younger women who might be considering fertility immediately, and surgery can offer more of a direct treatment option without having to go through cabergoline on and off. So acromegaly, the tumors that oversecrete growth hormone, and then this leads to high IGF-1 levels in the body from the liver. And so there's a number of symptoms and signs that are associated with acromegaly. And classically, we see these larger hands and feet over time. And a lot of these symptoms are very gradual, and it can take years for an acromegaly diagnosis to really come to fruition. And so here you can see the hand of someone with acromegaly versus someone without. And you can see how much thicker, more kind of swollen those fingers are, as well as the palm as well. And then this lady here, I think, has probably been in every medical textbook since the 1990s. But you can see how her face has really changed over time, from 1977 up to 1988. You can see that over time, the brow starts to protrude, more of the larger nose, larger lips, and then the jaw also becoming more prominent as well. Other symptoms and signs can be larger tongue, thickened skin, and then the development of skin tags. Patients with acromegaly often develop sleep apnea as well, just from kind of the soft tissue swelling that's in the throat. There's a higher risk and development of thyroid nodules and colon polyps, arthritis and joint pain, and then diabetes, high blood sugar, hypertension or high blood pressure, enlargement of the heart, and cardiovascular disease and heart failure are also not uncommon with people with acromegaly. And so the first line treatment, as I mentioned, is surgery. Hopefully that is, the main treatment, and that's that. But in some cases, there may still be residual tumor or residual disease. And in those cases, then medical therapy is often started. And so we have a number of medical therapy options that are available for patients, and they work primarily by one of two ways. So medications that would lower growth hormone production from the pituitary tumor, and sometimes can also decrease the pituitary tumor size as well. And these medications are generally injection types. So octreotide or lanreotide, pasireotide, medications that you might have heard of or maybe are on. And then medications that block the action of growth hormone. So pegvisomant would be a medication example of that. And in some cases, that is also still may not be enough to help control the IGF-1 levels in the tumor. And radiation may be part of the treatment plan as well. For people with Cushing's disease, they have pituitary tumors that oversecrete ACTH. And again, this tells the body and the adrenal glands to then oversecrete cortisol. And as I mentioned earlier, cortisol is a very important stress hormone. It helps for blood pressure. It helps for getting you up in the morning. But too much cortisol over time can lead to a number of problems. And so these are some of the classic symptoms and signs that we can see with Cushing's disease and high cortisol states. And so one of the classic symptoms or signs is this kind of rounder face, an oval face. And so you can see here kind of before and after one's Cushing's disease diagnosis. So this is what we call moon faces. You can also have development of fat pads along the upper back and in the neck area. Sometimes people will refer to this as a buffalo hump. And you can also see this kind of along the collarbones as well, this swelling of the fat tissue there as well. There's just general weight gain, particularly in the abdomen, whereas the arms and legs tend to be a little bit thinner and with a loss of muscle mass. And people can actually have some muscle weakness with Cushing's disease as well. Easy bruising is also not uncommon with Cushing's disease. And you can see these actually, these pink and purple stretch marks along the abdomen as well as other parts of the body. And if you run your finger actually along those stretch marks, you can actually feel kind of the skin thickness change. And that's just the thinner skin of where the stretch marks are. And the pink and the purple actually represents the blood vessels that you can actually see right underneath the skin. Also associated with Cushing's is diabetes, high blood pressure, osteoporosis or low bone density, as well as mood disorders like depression and anxiety. And so after surgery, again, we would refer these patients to surgery, but after surgery, we would actually hope that one's cortisol and their ACTH levels go down and are low. And then we would actually start you on some type of steroid replacement, usually hydrocortisone. And that would be a good sign for remission. But in some cases, patients still have higher cortisol and higher ACTH levels, and we need medical therapy to help control the hormone levels as well as the tumor. And again, we have several medical options that are available. They act in different mechanisms, some that lower ACTH production from the pituitary tumor, some that lower cortisol from the adrenals, and then some that block cortisol action. And again, radiation might be part of that treatment plan. One slide about TSH-OMA. These are very rare type, pituitary tumors, but it seems that we always have a few every year here at Stanford. And so we have pituitary tumors here that oversecrete TSH and tell the body and the thyroid to make too much thyroid hormone. So people can have actually symptoms of overactive thyroid, such as heart palpitations, weight loss, hand tremors, anxiety. Again, the treatment is going to be surgery, but sometimes can involve radiation or medication as well. So just one slide on Rathke cleft cysts, because these are not uncommon pituitary lesions that we also see. So Rathke cleft cysts are also benign, and they're fluid-filled growths or really kind of cysts that develop between the two lobes of the pituitary, the front and the back part. They're often small, and they usually can just be monitored over time. But some do grow large and can also cause headaches or changes with the vision, and eventually may need surgery or drainage. Similar to pituitary adenomas, they can also cause pituitary hormone deficiencies as well. Craniopharyngiomas are rare types of pituitary growth or benign growths that actually grow and extend above the pituitary, and they can also cause vision and hormone deficits just by where they're located alongside the pituitary, usually above the pituitary. Craniopharyngiomas are more classically associated with AVP deficiency, also known as central diabetes insipidus or DI. And so that's, again, where you have this loss of AVP hormone where folks are urinating very frequently, feeling really thirsty, and just trying to keep up with their loss of water. Some types of craniopharyngiomas can also be treated with chemotherapy, depending on the type. And so I want to also end with just talking about the endocrine evaluation before surgery and as well as after surgery. So anytime someone comes into our clinic, we would check all of your pituitary hormones at baseline. And then before surgery, we'd replace any hormones as necessary. And what most importantly would be things like cortisol, because that is that important stress hormone that you would need kind of to get you through surgery and potentially, the post-op recovery afterward. But if the pituitary hormone deficiency is maybe mild, we can sometimes consider waiting until after the surgery and checking later, because there is a chance potentially for recovery. For those who actually may not be undergoing surgery and we're just electing to watch these over time with MRI, we generally repeat hormone testing about once a year, or if there's signs of the increased growth of the mass. And after surgery, we check cortisol, we're checking your sodium, we're checking how much you're urinating here in the hospital, and we replace these hormones as necessary. And then 6 to 8 weeks after the surgery, you're usually seeing us back in the endocrine office or by online, and we'll have rechecked all of your other pituitary hormones as well. So your thyroid, the IGF-1, your sex hormones as well. And then for those with functional tumors, by 6 weeks, 3 months, 6 months, 1 year out, we're trending that hormone that you may have been overproducing. So for prolactinomas, we're trending out the prolactin. For acromegaly, we're trending out the IGF-1 and growth hormone. And then for those who have Cushing's disease, if you're not on steroids still, then we'd be checking urine cortisol and saliva cortisol tests. And so along the way, again, we would be replacing any missing hormones that may have happened before or after surgery. And so you'll hear more about hormone replacement later on in the day with Dr. Hoffman's lecture on hypopituitarism. And I just want to acknowledge again our great neuroendocrinology team. So Andrew Hoffman, our esteemed pituitary endocrinologists and really an expert and pioneer in growth hormone research. Susan Seav, who's recently joined our pituitary neuroendocrine group, as well as Olivia Chu, who I'm sure many of you have interacted with along the way. And Sarah Heilman and Linnea Rothi are also part of our pituitary team. And I also just want to acknowledge Larry Katz-Nelson, who has been the medical director or had been the medical director at the Stanford Pituitary Center for many of years and was a major mentor of mine throughout training and throughout my career as well. And so many of you have been patients of Dr. Katz-Nelson. And so I just want to take a moment to acknowledge him as well. All right. So with that, I will turn it over to Dr. Juan Fernandez-Miranda, our professor of neurosurgery and the surgical director here at the Stanford Pituitary Center and chief of skull-base surgery, neurosurgery.
Thank you. Is this? Is it a laser here?
So you hold the top button and then you move it and it actually.
Ready? Oh, I see. Okay. Well, good morning, everybody. It's so good to see you. So many patients, friends here. So I'm very thankful for seeing you all here, and it's good to spend the day and share this time with you. And I really hope that we can all get the best out of it. The goal of a conference like this is to give you the chance to interact with us, your providers, in a more informal way, but also for you guys to talk to each other and meet other patients that have been going through the same process as you, which only you understand much better than we do. And I think that interaction between you is patients will be of great benefit for many of you. I would like to start acknowledging Jenny, who's done an amazing job putting all this together. And Jenny is probably outside, still organizing, but she's a real inspiration and the driving force behind all of the efforts you see here. Of course, our clinical team, part of them, the clinical team you will meet today, and you'll see lecturing over the day. And I want to especially acknowledge our invited guest, Jill Cisco, president of the acromegaly community. She's been a phenomenal partner over the years. And there is no better advocate for one's work than patients. You are the testament of what we do, and no matter what we can say here is, your word of mouth is what really matters. And Jill Cisco has been a great supporter of our program here, for which we are very thankful. Leslie, president of the Cushings Support and Research Foundation, thank you for coming and joining us. Also a great advocate of our efforts to improve the life of patients with Cushing's disease. And I think we're excited to hear Catherine Jones speaking, and her perspective and how to help you from her advice is, I think, is tremendously valuable, and that's why she's here. I'm going to talk over the next 30 minutes or so about innovations in pituitary surgery and how these innovations have brought higher remission rates, better results. And this is a bit of a revolution in the last decade or so in pituitary surgery. And I'm going to try to share with you why we think that's the case. This is the first time I met a patient with a pituitary tumor. She was my grandmother-in-law, actually, and she had acromegaly. And I was a med student when I met her, is when I started dating my wife. I'm still with my wife after these many years, 30 years now. Yeah, I was a med student, and that's really impacted me, meeting someone with acromegaly, and she had gone through surgery, and for her pituitary tumor was the biggest ear in the world, and that really impacted me. And I didn't know at the moment, but I knew afterward that really was very impactful for me. I grew up and started my career in Spain, where I come from, in Madrid. I did med school there, and I did my residency training in Spain. But when I was finished residency training, I realized that the way to become the best possible surgeon is to really master surgical anatomy. And what we do in neurosurgery is very much, it looks that it's all about techniques and all the tools you have, but it's very much about the basic knowledge of anatomy to do surgery. And that's the most important. And that's why I had the honor to spend 2 years in Florida, almost 20 years ago. And I spent 2 years out of patient practice, just in a laboratory, learning and researching the intricacies of surgery and how to operate in tiny spaces and how to really learn the anatomy to do these operations. And I became an expert in anatomy, and that's why I published in Gray's Anatomy. And this is the most important book in medical school for anatomy, and I wrote the chapter on the anatomy of the intracranial region. Unfortunately, did not make it to the other Gray's Anatomy. And I really thought I could have made it, I was mixing well with them, but instead of that, I did continue my training. And I went to University of Virginia, where I met what I think is the best pituitarian of the century, perhaps, which is Dr. Edwin, who developed these techniques of removing the middle wall of the cavernous sinus for Cushing's disease in particular. And he was using the microscope at that time. That year, that really heavily influenced me. And at the same time, the next year, I went to University of Pittsburgh, where I spent actually 10 years there. But I spent 2 years first doing what is called a clinical fellowship, which is like the apprenticeship model, where you go with another students and learn from them. And I actually had the immense privilege of training with the pioneering group of what was called at that point endoscopic skull-based surgery. It's the introduction of the endoscope to do surgery through the nasal cavity. And that was a revolution in pituitary surgery and in skull-based surgery at the time. It was the first center doing it, and the center developed many of the techniques, and I was part of that process. And imagine that, going from the microscope to the endoscope is a huge change. The endoscope gives you this tremendous panoramic view. You can see better, so you can do better. But also we had to learn over the years what we were seeing and how to deal with the new anatomy we were seeing. And that was my main goal during my 10 years in Pittsburgh, where I spent a long time in the OR doing many cases, but also doing research on trying to advance and understand this anatomy, this new anatomy better. And we built over the years tremendous experience there. But for example, I can tell you that at that point, we were starting reviewing our outcomes in, for example, acromegaly, and our outcomes were quite discouraging. We were only getting remission rates in about 50% of our patients. And this is was the same across the board. This is a meta-analysis where they look at multiple other series where that was the remission rates, about 50%. So that wasn't good. And we understood that cavernous sinus invasion was the main reason why the remission rates were not so good. So what is the cavernous sinus? The cavernous sinus is a venous cavity that is on each side of the pituitary gland. We have the pituitary gland in the center, and then the cavernous sinus is on the side. And the deal with the cavernous sinus is that it contains the carotid artery within. And the carotid artery is the main pipeline going to each side of the brain. So it's a very important structure, of course. And getting into the cavernous sinus has a potential risk of injuring the carotid artery. And that is the main concern and the main reason why until now, we were very hesitant to go into the cavernous sinus to do an operation there because of the potential risks of injuring the carotid. But instead of accepting the status quo, we tried to embark into this quest to understand better the anatomy of the cavernous sinus and see if we could do better. And you can see here a nice illustration of, this is the most realistic illustration we've developed of the pituitary and cavernous sinus area. And you can see clearly, there is the pituitary in the center. This thing in the center is the pituitary right here. And then the cavernous sinus is all this area right here, but it has different layers. You can open one and you see ligaments that attach to the carotid artery. And this is very intricate anatomy, but we basically understood that this membrane that surrounds the pituitary gland, which we call the medial wall of the cavernous sinus, has these ligaments and that attach to the carotid artery. And tumors might embed into this membrane, and understanding these relationships with the carotid artery are key to really detach this wall and the tumor that is embedded in it. There are many things we studied over the years, different parts of the cavernous sinus, how to get there, how to navigate inside, how to go around it, many details that we described over the years, many publications focusing on how to do better operations here. And all this work is what brought me to Stanford in 2018, bringing this surgical innovation in pituitary and skull-based surgery. And I came here in 2018 and with the dream of building a unique program on pituitary and skull-based surgery. And I believe we've done so with the help of many of my team members. And this technique of the medial wall resection, which was awarded by the Skull-Based Society in 2018, is a technique that, again, is based in that anatomy. We go step by step, understanding how to remove this membrane. And again, the relevance is because many tumors do embed into this membrane, and you don't remove this membrane, some tumor will remain. And if you have a functional tumor like acromegaly, Cushing's disease, prolactinomas, you will still not be in remission. So we developed this technique. We also developed instruments to be able to do this technique. These instruments I designed myself, working with industry, and these are my instruments. And now these instruments are being sold over the, all over the world, over many countries, over 20 countries have been sold, because this helps other patients do better, other surgeons do better surgery for their patients. So I'm going to show you basically in this cartoon, maybe some of you have seen this technique of going the surgery through the nasal cavity. We can actually introduce instruments through each nostril. On one side, the endoscope, and on the other side, dissecting instruments such as micro scissors. With the collaboration of our ENT colleagues, we proceed with opening of the sphenoid sinus. These give us access to the posterior wall of the sphenoid sinus, where we can identify the prominence of the pituitary gland, carotid arteries, cavernous sinus, and optic nerves. Here we can see the location of the endoscope inside the sphenoid sinus and the close-up view it provides. We use a high-speed drill to carefully remove the bone that covers the pituitary gland. We continue drilling laterally to perform a wide exposure into the anterior wall of the cavernous sinus on each side of the pituitary gland. We perform this XL technique where very thin bone is left behind, so we can use a kerosene ranger to remove it safely and entirely. After the dura has been widely exposed, we perform our cruciate dural opening. We use micro scissors to open the dura in a cruciate fashion up to the level of the medial wall of the cavernous sinus. After widely opening the dura, we start identifying the difference between the pituitary gland, which looks well vascularized and more orange-like, from the pituitary tumor, which is less vascularized and more whitish or pale in appearance.
By identifying this interface between both the pituitary gland and the tumor, we can develop an accurate plane of dissection to separate the tumor away from the pituitary gland. Whenever possible, we aim to perform an extracapsular dissection of the tumor to accurately separate it from the pituitary gland. In certain cases, tumors invade the medial wall of the cavernous sinus, and this poses a special challenge. For this, we have developed an original technique which consists in opening the anterior wall of the cavernous sinus to directly access the inside of the cavernous sinus and remove the medial wall. By directly opening the anterior wall of the cavernous sinus, we can identify the carotid artery in the cavernous sinus, the inferior hypophyseal artery running towards the posterior aspect of the pituitary gland, and we can gently separate the medial wall that contains tumor from the cavernous carotid artery. The medial wall of the cavernous sinus can be removed en bloc by performing the disconnection of the carotioclinidal ligament superiorly and the disconnection from the dural floor inferiorly. During this process, it is important to identify and typically coagulate and transect the inferior hypophyseal artery. At the end, we can achieve a complete tumor resection, including a complete removal of the middle wall of the cavernous sinus, which makes significant difference in patients' outcome, especially for functional pituitary tumors. As a conclusion, the endoscopic endonasal approach allows us to perform complete tumor removal with excellent preservation of the pituitary gland function secondary to the superior visualization provided by the endoscope.
So, that was an illustration of how surgery is done. I'm going to show you how surgery is really done. So, just bear with me. But when we started doing the first series of cases here over the first 2 years or so, we collected 25 consecutive cases in this particular case of acromegaly. And there is no selection bias here. All cases we did. And we were able to, in 23 out of 25 were in remission. That's 92%. It's a small series, but that's 92% increasing from our previous experience of 50%. So we were able to start proving that this technique really makes a significant impact in patients. Not only that, but we also started learning things about how these tumors behave. And we described different ways these tumors invade the cavernous sinus wall. Some of them, they have really no invasion. Some others have just a focal or microscopic implant, a small implant. Some others do grow completely along the middle wall and thicken the wall, which are more difficult cases. And some of them have the more classical destruction and invasion into the compartment of the cavernous sinus. And this is very new. This is so new that it's not even published. The paper we're submitting it very shortly, but we've seen that these different patterns of invasion of the wall of the cavernous sinus have peculiar characteristics, like certain tumors, like for example, growth hormone adenomas tend to have more focal invasion, while ACTH adenomas that cause Cushing's disease cause more often wall thickening. And we see that the remission rates are different, very high if it's just focal invasion. The lowest is when you have wide invasion with wide distraction. So we're learning new things about how these tumors behave. And I'll show you some examples. These are real operations. Here is a patient with acromegaly. He has a tumor like this one you see up there. And then this membrane you're seeing right there pulsating, that is the normal middle wall of the cavernous sinus. See, the tumor is being removed. We see this membrane. The carotid is on the other side. The carotid is on the other side of this membrane right here. But this membrane here, if I'm able to move this membrane right here looks all intact. And the carotid, you don't see it, is on the other side. But we are carefully exploring, and we see that that wall is all clean. There is no tumor inside. So we don't remove it because it looks clean. We just let it be. This other case, for example, this is a patient actually from UK and has this tumor. And when I look at the imaging, there is a little something here. Makes me think maybe there is a focal invasion. As you see, this patient, as you will see here in the operation, has a small nodule that is growing into the wall of the cavernous sinus. And that is easy to miss. If you do conventional techniques where you don't expose the wall of the cavernous sinus and you don't look for it, you miss these things. And this is a small implant right there. So we're opening the wall of the cavernous sinus. Now we are seeing the carotid artery right on. This thing here is the carotid artery right in here. And then we're peeling this membrane, which is which is this membrane right here. And it has a nodule there of tumor. And that nodule of tumor now is removed. And then this patient got in remission, and he's 5 years now out of surgery and continues to be in remission. So those are the relatively easier cases, focal implants. As we learn more and more, we have patients like Ali, who I met a few years ago. And when I look at his case, he had already 2 operations in the past. And in the Middle East, had multiple opinions of what to do. The kid was so driven. He wanted to find a way to solve his problem. And they said, there is probably no solution for your problem. Maybe try radiation or adrenalectomy. And looking at his imaging, there is something right in here. So Ali had the classical pattern of thickening of the wall of the cavernous sinus. In this case, the tumor is actually within the wall and grows within the wall of the cavernous sinus, like as you see right here. This is thickening of the wall right there. But the beauty of this, the tumor is still contained within the wall, and you see it right here. And the tumor remains attached to the carotid artery by these same ligaments. So you find those ligaments, you transect them, you can remove this bit of tumor that is in the wall of the cavernous sinus entirely. And this is a life-changing operation for Ali and for many patients. The change over the years. He's a healthy young patient now, and last time I heard from him, he's going to become a neurosurgeon. And I'm sure he will become a neurosurgeon because he's so driven that he will accomplish that. Patients with Cushing's disease are sometimes very tricky because it's difficult to find the tumor, and those that have deal with Cushing's disease know well that these tumors are very tricky. They have what is called a negative MRI. You do an MRI, you look at the pituitary, you don't know what the tumor is. So these tumors can be just a few millimeters, and finding these tumors remains a challenge. The role of endocrinology team for these patients is extremely important because they need to do an accurate diagnosis with all the testing that you see here to make sure first that the patient does have Cushing's disease, confirming that it comes from the pituitary. But when the MRI is negative, you have to do what is called the petrosal sampling. You probably heard about this testing where through your groin, they put these catheters to measure the amount of hormones coming out of directly of the pituitary gland. But we are doing something like a new MRI sequence called LAVA sequence. We can actually see that shadow right there. And sometimes we can find tumors that were hidden, invisible before. So we had a hint of a shadow right there, and then we go after these tumors. And then this is a different type of technique because this is finding small tumors. This is what Dr. Oldfield was so good at, and finding these microscopic tumors within the pituitary gland. You see the pituitary gland is all exposed there and looks a normal gland. So you have to slice into the gland and find, it's like find a hay in a stack. It's find very small tumor within the normal pituitary gland. And you do it by very carefully inspecting the consistency, the tumor tissue consistency, the appearance, basically how it looks and how it relates with the surrounding normal pituitary gland. So it's very tricky, something that you only develop with a lot of experience. In addition, we found in some of these cases, actually like in this one, was not just hidden within the gland, but also was embedded into the wall. It had a very small invasion, but the wall of the cavernous sinus was also embedded here. And then what we're doing here is removing that membrane, again, from the carotid artery, where there is a nodule of tumor. You can appreciate how that membrane is thickened and has tumor inside. So if you leave, again, this membrane there, this patient will not get into remission. And the issue is that you are separating this literally from the carotid artery. So you have to be extremely careful in doing this maneuver here. And you can see that is this chunk of tumor there, chunk of tissue that is the tumor. This instrument I'm using is a Doppler. I can hear the carotid artery. I can hear the pulsation of the carotid when I'm operating. So I can map the carotid as I do this operation. This is an indocyanine green. We can use a dye. And you see in green is the carotid artery. You inject it in a vein, and it goes into your carotid artery, and you can see the carotid artery during surgery because it highlights in green. And this patient, of course, in remission after such an operation. So we've learned this technique in many patients, some of these patients that have tumor in the wall of the cavernous sinus, it becomes very difficult because the wall is extraordinarily thickened and then it's very adherent to the carotid artery. This young woman from Ohio came with this very large tumor. It was both it's a co-secreting growth hormone and prolactin adenoma. And you see, this is the gland in this case. You need to also find, when you do pituitary, what is the normal gland, what is the tumor. We always preserve the pituitary gland. We find the interface between the tumor and the gland. And in this case, we remove all the tumor on the pituitary side, but now all this extraordinarily thickened area right here is all tumor. And I put this video so you can see also how these operations are very difficult because you're working in the cavernous sinus, which is a venous cavity, so it bleeds. So you're constantly dealing with some venous oozing that you have to tamponate, and you have to work through this, and you need to see through this. And that's why it's so important that you have excellent understanding of the anatomy in your mind. You need to understand three-dimensionally the anatomy here, and you need to be able to even identify anatomy in a field like this, like in a battlefield where it's all difficult to navigate sometimes. But this young woman from Ohio is in remission years after this operation. This other patient also with acromegaly from New York with this large tumor, and same situation. The tumor is totally embedded within the wall of the cavernous sinus. Look at this is what we call an expanded cella. You see the tumor has grown and has made the cella of the pituitary very enlarged because it's all full of tumor. And what we're doing here is, you see the blue on this side. This blue is the cavernous sinus. And until recently, until now, most pituitary would stop at the cavernous sinus. We just remove the tumor, which is in the cella. We would stop at this point. But the problem here is that there is still tumor in there. And the tumor is right in here. You can see this area that I'm touching right now clearly tells me that there is tumor in this area right here. And what do you do now? So this is like a membrane. So I see there is tumor on one side. I need to go to the other side. The other side has the carotid artery. So I'm opening this membrane and I start seeing that this membrane is not normal. You can see these yellow nodules on the membrane. Those yellow nodules are tumor. And those are stuck to the carotid, which is this thing right here, this big pulsating thing right here. And the challenge here is, of course, if you're not careful and you put a hole in that carotid artery, that is high pressure bleeding, very difficult to control. It could be life-threatening if that happens. I'm happy to say that I've done this hundreds of times, and I've had an injury to the carotid artery twice, and both patients are alive and doing well. One of them is with us today here, and she's doing fine. She never had any sequelae from that, which is very fortunate. But this patient, we do this operation, and again, she's in remission. And these are young patients, 21-year-old, 24-year-old, coming from different states to have surgery with complete remission. And these patients come from word of mouth, like from Jill and other patients that recommend them coming here. They don't come often from endocrinologists. And nothing against you, Julianne, Susanna, at all, but it's that some endocrinologists still do not believe that these techniques are this highly effective. And they believe that medication is the way to go, or they believe that radiation is the way to go. And it sometimes is, because our remission rates are not 100%, but they are very high, and we can offer better outcomes for our patients with these techniques. Even for the most difficult tumor cases, which are like this patient actually came from Italy with this very invasive tumor into the cavernous sinus. And this is the last pattern of invasion where the wall is actually destroyed. And the tumor is really invasive. And it's stuck to the carotid, and there are nerves in there, especially this nerve, for example, you see here is the nerve that controls eye movement. It goes to one of the eye muscles and moves your eye lateral. So one of the most common side effects of these operations, which happens, as I'll show you, in 5 to 10% of cases, is transient double vision. You have like a lazy eye. Your eye doesn't move all the way. And you see in green, that is the carotid artery. So we have basically removed the carotid completely of that carotid artery. The carotid artery actually has a robust wall. So you can work and navigate around the carotid artery quite safely. So some of these patients get double vision. that they get better after some time because of those tiny nerves in the cavernous sinus. This other patient, this patient had another operation in Israel, and he was told, your tumor is very fibrotic, it cannot be removed, and you just need to go for radiation. And I believe we could remove, and we did remove his tumor entirely, and he's in remission after a number of years already. And again, these are life-changing operations for many of these patients. This other patient, same, also from New York, with this small tumor after an operation. And this is something that many patients face. Should I have residual tumor? What should I do? Should I go for medication, which is a very reasonable option? Should I go radiation, which is also a reasonable option? Should I go for a repeats operation? And it depends. Each case and each patient is different. Not all of them are good for surgery. Some of them is better if we do radiation or better if we do medication. But this patient, and some patients, and I'm always admiring the bravery of many of you, they just prefer surgery because they know it's a more definitive option than medication or radiation. And this is what this patient chose. And she's a well-known blogger in Twitter, former Twitter, now X, and she was very thankful because I was the only person willing to do what she wanted to do, which is surgery for her tumor, and she is in remission. And like that, many stories. Another patient, it's not only about the cavernous sinus. This patient, for example, had another tumor with acromegaly. There was some tumor left over, but not in the cavernous sinus. It's stuck to the optic apparatus. And this is another level of complexity. This tumor was, you see what you see there in white? That is the optic apparatus. Is just the optic nerves going to the back of the eye. And this tumor was growing towards those optic nerves. So now we're in a different space. We're not in the cavernous sinus anymore. Now you're seeing the carotid artery, but this is the carotid artery outside the cavernous sinus, into the fluid spaces of the brain. And here we are in an area where all those little vessels you see there, little branches, are very important. They go to the optic nerves, they go to the base of the brain, and injury, some of those can be devastating. But we can remove the tumor, preserve all those little membranes, and this patient also in remission after a number of years. So this is the best compliment I can get is this patient that want to get a picture with me with a big smile on their face, because this is what it really is about. And sometimes we cannot help all of our patients get a cure, but we can help them be in a much better place. This patient had this extremely invasive tumor that we could consider incurable with an operation because it's so invasive. There are some limits of what you can do. It's a small number of patients, but some we cannot completely cure. But this patient from Chicago came with this tumor. He was offered craniotomy, different options, and we did an operation, removed, I would say 99% of the tumor. There was a little bit that was so stuck to the carotid we could not completely remove. But this patient is in a much better place. His numbers are much better. And now we can do radiation, or medication is going to be much more effective. So even for those we cannot cure, surgery makes a big difference. We do believe, and you'll hear from our radiotherapy team, my perspective on radiotherapy has always been that should be the last resort when you've exhausted surgical treatment. When surgery is not curative, cannot be effective enough, we can prepare actually the patient for a very effective low-risk radiation therapy. And that was what we've been doing for our patients. You'll hear more in detail. And we also develop these techniques where patients, when I do an operation and I see that there is some tumor stuck to the carotid artery, to an area they cannot completely remove, I know that the next best step is going to be radiation to cure this patient. Focal radiation, CyberKnife ideally. And then we clean everything as well as we can. There could be some residual stuck to that green thing, the carotid artery. And then what we do is I'm going to place this piece of fat right there. That piece of fat we take from a small incision in the abdomen. That piece of fat is going to separate the pituitary gland from the carotid artery. And if we are going to do radiation, then that pituitary gland is going to be protected from radiation. And that makes a big difference. The main side effect of radiation is pituitary gland dysfunction. With this technique, the pituitary gland dysfunction will decrease dramatically. So yeah, we've been fortunate to treat patients from so many states in the United States and from abroad that come for surgery. We like to be fully transparent about our outcomes and our results. And I'm going to briefly show you some of our numbers without boring you too much. But we have, first thing we can see here, this is a bit up, is from the last year, but almost half of our operations for all pituitary tumors across the board require to go into the cavernous sinus. It's not a minority, it's half. And if we consider only the ones that we have that have been operated before, it's the majority of them. We're operating them because they have residue in the cavernous sinus. So this is actually a routine thing and something we do and we see very often. When we look at resection rates, this is not remission, resection rates, meaning how much of the tumor is left or gone. So we are able to achieve gross total resection in the majority of patients. 91% of our patients get complete resection. 98% if we are not, it is not in the cavernous sinus. 82 if it's in the cavernous sinus. And the numbers are like 10 points lower if we are talking about residual or recurrent disease. These are typically more difficult cases because of scarring and because of more aggressive tumors, etc. When we look at biochemical remission rates, which applies for functional pituitary tumors, we can see that remission rates across the board are between 80 and 90%. And if we add on top of that additional treatment like radiation or medication, the numbers are in the high 90%, 93, 96, 92, 93. So really, we can get in remission most of our patients, not all, but most of them. In particular, for example, for acromegaly, in our last 77 patients, we've increased our remission rates to, it was 92% in the first 25, as we do more complex cases, we have now 89% remission rate, which is also outstanding because previous it was about 56%. But also redo patients, which are the ones that often hesitate to have surgery. And we have remission rates that are double as, we have doubled the numbers from 46% to 83% remission rates. So really providing excellent outcomes and hope for our patients. And we always have to wonder at the expense of what risks, what consequences. And the reality is that we had no patient with a stroke, no patient with meningitis, no patient with permanent morbidity. There are a number of patients that have diplopia. It means double vision after the operation. The risk of double is the main risk after the operation. Double vision, of course, happens mostly on the patients that we have to go into the cavernous sinus, and especially if it's a re-operation. Those are more difficult cases. It can be as high as 13% in some of our patients, you see there. But the good news, if these patients that have double vision, this is the curve of recovery. At 3 months, half of them have recovered, and at 6 months, all of them have recovered. And it's because these nerves are not permanently injured, they're just irritated by us being in the cavernous sinus and removing the tumor from those areas. So it really, these operations are really all about working around the carotid artery, understanding these compartments, understanding these ligaments, understanding the different segments. It is really complex. It's not easy to get here. It really requires a lot of experience and dedication, commitment to do these techniques and these operations. That's why when you are a patient and you're going to have a pituitary operation, you need to make sure that your surgeon is highly experienced. And it makes a big difference who does your operation. And my goal is not to have all patients come here to Stanford to have an operation, by no means. My goal is that the level of pituitary surgery is as good as possible everywhere. And that's why we have our research and clinical fellowship training. We train people to come here and surgeons to learn our techniques. We do courses every year. Did you see our annual courses? This last one in 2024 was exclusively on these cavernous sinus techniques. We trained, about 50 surgeons from the United States and abroad on these techniques, so they have the first steps, so they can start, improving their outcomes for their patients. And that's been our goal here at Stanford. I want to finish showing one more case, which is special for many of us, because we talk about the pituitary, but also there are other tumors in the pituitary that are called craniopharyngiomas. And you heard Dr. Chang talking about this. These are tumors that come somewhere along the pituitary and the stalk. This is the hypothalamus. This is the stalk that reaches the hypothalamus, one of the most complex and important areas of the base of the brain. And I've treated also many patients with phenomangiomas, hundreds of them. And sometimes this happens in children. And of all the operations I do, every operation is gratifying, especially when you have a good outcome, everyone. But when you operate on a child, like this one, was 2 years old when I met him, it is even more special because you change the patient's life, hopefully for long. This patient had this phenomangioma that was treated somewhere else with a catheter to drain the cystic component of the tumor, but the tumor continued growing. And the patient was losing vision. You can see how cute he looks with his little glasses there. He was getting blind from this tumor. And the challenge of doing this operation to the nose in kids is that, really younger than 4-year-old, is that the sinuses that we use to enter the skull base are not pneumatized. It's all hard bone. And of course, it's very narrow. These are tiny noses, right? And the inside cavity is small. And you have a big tumor right there. So how are you going to remove such a big tumor through small nostrils? But we learned how to do this over the years. This patient came here to Stanford for this operation. You see the big tumor there. And what you're seeing here, this is one optic nerve, so briefly on one side. All this you see, there is a tumor. We're surrounding it. And what you see on the top here, those are the optic apparatus. Those are the optic nerves on the optic apparatus there. This here. Look at all these little tiny vessels going to the optic nerves. These two things, those were the mammillary bodies. Those are part of the limbic system and the memory circuit. So if those are injured, you basically have no short-term memory anymore. That's the tube that was placed initially. We are cutting it. And then we are finally removing all this tumor entirely in block. You see that's the basilar artery. This is one of the most important real estate in the brain right there. And you can see the beauty of the anatomy inside. And after we remove all this tumor, you see here is these are again the mammillary bodies, these two right here. And then this is the third ventricle. This is the hypothalamus. The hypothalamus is a critical part of the human brain. And remove this tumor entirely. And this kid, who is the cutest kid you can find, he was going around in the hospital, as you see him, saying, "My tumor is out, my tumor is out." This is literally true. And he was the cutest kid. He's now 1 year after his operation. And he's doing great. He's free of tumor and carry on with his family. And this is what fills our practice with joy. So just to conclude, as you see, this is a long journey of building a base on anatomy and technical innovation, because this makes a difference. We can do better for our patients. And again, we want to spread this to endocrinology so they know that we can do better, and to other surgeons so they know they can learn these techniques and do better to the patients wherever they are. Thank you very much. I believe we will have time for questions and anytime, but while we set up, if anybody has any questions, I'm happy to address any, but we have the whole day for questions. Please.
Any therapies? So I had a craniopharyngioma, 50-something, about 7. Everything is good except I have to take a lot of medications for hormone. Are there any therapies coming down the pipe where the pituitary can be repaired?
Yeah, that is a wonderful question. Not that I know of, but I think the question is a very important question, and I think we'll have a panel later on, or Dr. Hoffman will talk about hypopituitarism. It's about, how do you, is there anything to treat hypopituitarism, to, the damage to the pituitary gland with the need for hormonal replacement? And there is nothing yet, but it would be wonderful if they are able to develop a synthetic pituitary, right, or something. Not that I know yet. If you ask what I would think, my best estimate would be that we develop something more in the line, not of stem cell therapy, which sounds ideal, but I think that's more difficult biologically, but with new techniques, new chips that can deliver medication in an automatic fashion based on homeostasis, things like that. That will come, but it might take a number of years. Yes.
So my surgery was about 17 years ago or so, transfenoidal surgery, and afterwards resulted in a lot of hormone replacement that was necessary. So
Yeah.
in your new studies, what percentage of patients after a pituitary surgery have damage to the pituitary that require hormone replacement?
So it depends. First, you need to look at how many have pituitary dysfunction before the operation, because there are many patients that already have some pituitary dysfunction before the operation. The tumor, just think that the tumor grows in the pituitary gland itself. These are tumors of the gland or the pituitary gland. As they grow, they compress the pituitary tissue, and they have complete or partial damage of the gland before the operation. With pituitary surgery, we are not very good at recovering pituitary damage. Only about 25 to 30% of all patients will get better function. Now, if your function is good before the operation, is intact, it's only about 5% that will have some degree of pituitary dysfunction after the operation. So it's not common. And these techniques, they are not better at that, but they're not worse, which is important. Being more aggressive, meaning going to the cavernous sinus, moving tumor from there, does not, and we have studied that, does not increase the risk or the incidence of pituitary dysfunction. Thank you.
One more question. Dr. Miranda, one of your slides mentioned that the patient went through 3rd surgery in order to be symptom-free.
Yes.
How often or how rare is it? Could you comment more on that?
It's not very common, but there are some patients that have undergone multiple operations. Some of them have come to, usually operations that have been done somewhere else. And they are usually operations that have been done, they're not very thorough operations. Perhaps they left some tumor behind, things like that. I rarely reoperate myself on that patient, but I might, if I've done everything I can in the first operation, I don't think I can do better, then I would not do another operation. I would recommend, for example, radiation. There are exceptions though. If the patient has new tumor growth that is causing symptoms, then a reoperation is important. But yes, if your question is, can you reoperate on a patient multiple times? The answer is yes, you can. There are a number of factors you need to consider, like, reconstruction techniques, things like that. But yes, patients can undergo multiple operations, and often the reoperations are easier on the patients. They are more difficult on the surgeon, but on the patients, they're easier because the sinus are already open. Some of the, let's say, destruction has already been caused by the first operation. So there is less damage caused by surgery.
So if the patient, if you did the operation, then the repeat surgery is a no. That's my take of it. Is that right?
Yes, unless there is a significant new tumor growth. But if I don't see any, if I see a little bit of tumor that I left there because it was stuck to the carotid and I couldn't remove it at the first operation, I'm not going to try to do another one because I don't think I'm going to be able to. Then I would say, Dr. Rahimy, please do CyberKnife for this patient if you will.
I like
Okay.
to think of Dr. Fernandez-Miranda as the neurosurgeon's neurosurgeon. So for all the neurosurgeons who need a neurosurgeon, then they ask him.
Yes, some neurosurgeons do refer me cases. That's more than endocrinologists, perhaps. Okay, one more.
So,
En
my
español está bien.
doctor mentioned supercellular.
Sorry, say that again.
There was some mention of supercellular. You didn't mention it, but I heard somewhere there's a supercellular. Then second, with a short memory, then the optical tract, there's an optical chiasm, or
Yeah, the optical, yeah,
where is located compared to the pituitary gland?
just above. The optic chiasm is above the pituitary gland.
So they crossing right above the pituitary gland, or?
That is correct. Yes.
So it's, the tract goes above the pituitary gland, there's the pituitary stalk, and it's right there.
Yep. The
Okay.
pituitary stalk goes just underneath the optic chiasm.
Okay.
Yes.
And the memory, short-term memory,
It's like below and behind the optic chiasm.
And I forgot fourth. No. Oh, what happened if say you mentioned there's a carotid artery, and what happened if it gets penetrated? How is it fixable? Even like super glue or?
We don't have super glue, unfortunately, for that. So there are a number of things that when a carotid injury happens, the first thing you need to do is control the bleeding. The second part is assess the injury. Is it a small hole that is fixable? Is it a large hole that is not fixable? Sometimes the easiest solution is just to occlude the carotid, just pack it with compression or with a clip. Different ways of doing this, relying on the patient having the other carotid being able to give flow to both sides of the brain. This happens in 70 to 80% of patients. Of all of us, 70 or 80% of us will have good cross flow from the other side. So you can live only off one carotid with no stroke. And this is great. We have a circle called the circle of Willis at the base of that connects all the vessels in the brain. You have a well-developed circle, you compensate really well. The problem is the 20% that don't. So you have a small hole, sometimes you can fix it. You put a sidewall clip, you can put a muscle patch. There are different ways to try to repair it. But sometimes it's unrepairable, you just have to occlude it.
What happens if the tumor actually engaged the optical nerve? And I know there are some different kinds of tumor, they try to adhere to stuff really hard.
Yes.
And also one more question, how do you fix the hole that you make in the nose? Do you leave it open or just grow together again?
So about the optic nerve, most pituitary tumors they can compress the optic nerve, but they have a nice membrane that separates and protects the optic nerve from the tumor. You can separate one from the other. Now there are a subgroup of pituitary tumors, which about 5 to 10%, which we're actually studying, which have what is called subarachnoid invasion. These tumors do go through those membranes, and they can stick to the optic nerves really badly, and those are very difficult to deal with. And in those, I show you one case of those. Those are difficult. You need to dissect carefully away from the optic nerve and the little vessels. Yeah, those are more difficult. About how you fix the hole, the sinuses themselves, they remain open. The most important thing is when the pituitary tumor breaks into the fluid spaces of the brain. Then you have to separate the fluid space of the brain from the nasal cavity. Because if you don't do so effectively, you can get an infection. You can get fluid leaking, meningitis risk. So you have to close that. And for that, the most efficient way is using what is called a septal flap. The septum of the nose has skin on each side. We use the skin on one side of the septum, and we rotate that and we put it up there. It's the patient's own mucosa of the nasal cavity. We keep the vascular supply, so that heals really well. It's the best and most efficient way of doing this. There is some scuba diving. There is some discussion about where you can. I believe you can if you have a robust 3 months after the operation. Yes.
All right. For the sake of time, I think let's move on to the next
thank you,
session
thank you.
with Dr. Rahimy.
Anna, we'll go for your question next, okay?
We have many opportunities to have your questions answered during the breakout sessions and then the Q&A. And you're always welcome to come up to us during the breaks.
Thanks for keeping us on track. So, El, it's great to have you. El is a team member of the radiation therapy team, key part of our pituitary practice. Thank you for joining us.
Thank you. So, oh, thank you. Lovely. So this is the first time I've been invited to this event, and it really is an honor. A lot of my interest in the department is centered on patient education and empowering patients so they can understand their disease and the treatment options, because a lot of the most frightening aspects is not understanding. And before I get started, I do want to say that I have a bone to pick for whoever decided that I would be following up Dr. JFM. I assume that's Jenny, so we will be talking afterwards. Okay, so I'll talk about radiation therapy for pituitary tumors. I'm Dr. Elham Rahimy. obviously, like has been stated by others, there's other people who are part of this big team that are not here. So I'm one of the Stanford radiation oncologists that specialize in CNS. CNS means the brain and the spine. And so these are my other colleagues. Radiation oncologists in the community oftentimes are generalists, so they'll treat everything. Here at Stanford, a lot of academic places will subspecialize, like with neurosurgery and oncology. And for example, my subspecialization is primarily CNS, but I also treat GI tumors and I treat patients who have very advanced cancers that are metastatic. Just because radiation oncology is very confusing and complex, I thought I'd just give a little background. Actually, there's a lot of background kind of scattered throughout the slides, assuming that you don't know anything about radiation oncology. So oncology does mean cancer, but it's a little bit misleading because we do treat mostly cancer, and the intent can be to either cure patients, so you give a very high dose, very complex treatments, can cause side effects. They usually get better, but the intent is to cure the patient, versus to palliate. Again, I mentioned I treat patients with metastatic cancer. Sometimes I cannot cure them, but I can help with their symptoms. So I give a lower dose of radiation. I can help with pain and other issues they might be having. But we also treat benign tumors with the intent to control those tumors, to cure patients with those tumors. For example, pituitary adenomas and pit nets, as Dr. Chang mentioned, you might see that term on your pathology. So there's been a transition to calling these pituitary adenomas a different term, which is neuroendocrine tumor, vestibulocarcinomas, meningiomas, but we also treat non-tumors. So I just listed a bunch here in their medical names. I won't say them and go into them. And there's many more that we treat that I didn't list. But it's just to say that radiation oncology is much more than just treating cancers. Obviously, we treat benign conditions, whether that's benign tumors and even non-tumor conditions. And then I have some slides just to give examples of what we treat. With Dr. JFM's slides and Dr. Chang's slides, a lot of the imaging, MRI scans that are shown as if you're looking at a patient. So looking face on, so those are called coronal scans. In radiation oncology, because of when we do our treatments, our treatment delineations, we usually go through the MRI in an axial cut. So it's like you're looking down on a patient. So just FYI, the MRIs can look a little bit different in terms of their orientation. So I might draw your attention to that. Just in kind of a general context before I go on to those examples, there's different types of brain radiation. So if you know somebody who's had brain radiation, it can be very heterogeneous in terms of what they might have had. There's whole brain radiation. That's where you treat the entire brain to a low dose of radiation. And this is to help palliate, meaning patients might have tumors causing symptoms. You're not going to focally treat something because there's too much tumors. So then you treat the whole brain to a safe low dose and you help with those symptoms. Then next on the picture, it mentions traditional. So this is what's termed VMAT radiation, 3D conformal radiation, special techniques. All it means is you're not treating the whole brain. You're focusing on a certain part like a tumor. You're applying some margin and then you're treating that tumor. And then there is SRS. So Dr. JFM referenced CyberKnife. A lot of times in Stanford, when we say CyberKnife, we're referring to SRS. That means that you have a very focal area, very well delineated, and you're going to give a very high dose of radiation to that region. And then you see there's almost no green or blue to the rest of the brain because you're sparing the rest of the brain. But there's appropriate times to use each one. So SRS is not always the right answer, but there's all this kind of spectrum of treatments. So some examples, these are patients with brain cancers. These are cancers. The top image is the patient I treated who had a very aggressive brain tumor called a GBM. She received radiation treatment. So this was the imaging that said traditional, like a focal type of radiation treatment, but not on CyberKnife. You're just treating the area of the tumor, some margin. She's doing very well after that radiation treatment. It's helping to control that tumor. The bottom is a patient who had an excellent surgery with one of our surgeons here for an aggressive meningioma. And then a nodule showed up on his scan and started growing. So we radiated that with CyberKnife. So when you see imaging that looks like the bottom panel, that's the CyberKnife. And I think you can see, yeah, my arrow here. So this is kind of just showing the patient. This is kind of a coronal view. So looking at the patient, And these blue beams are the radiation from the CyberKnife coming in very pinpoint just at that nodule, and they spare the rest of the brain. And that nodule is being controlled after the radiation. The top left is a whole brain radiation treatment. I won't get into the nuance, but this one we are sparing the hippocampi. So that's why there's a hole here where there's no color. So these are some memory structures of the brain. So it's a fancier radiation treatment where you treat the whole brain, but you're kind of sparing some structures for memory. So this patient had breast cancer that had spread to the brain, and she had many tumors throughout the brain that was causing issues with headache, nausea. She had arm weakness, leg weakness. So we did the radiation, again, a low safe dose for the whole brain, and she benefited from that. So her symptoms got better. Very minimal side effects. Bottom right, this is a CyberKnife. This is not brain, so this is spine. And again, this is a kind of showing a patient, you're looking at them head on, well, kind of here. And these are the beams from the CyberKnife radiation coming in and treating this very big spine tumor. This was from a colon cancer that had spread to the patient's spine, causing severe pain. He was in bed, he couldn't get out of bed because of pain, and he had an excellent response and is now no disease. And then some examples for benign tumors, again, non-cancer. Top right, these are both CyberKnife. We usually try to treat on CyberKnife for a lot of benign tumors because it makes sense for different reasons, which I'll get to. This patient in the top right, so CyberKnife plan, he had a meningioma, so a benign tumor. Surgeon removed much of the tumor, did an excellent surgery. Oftentimes, so it's kind of this area of the brain next to the sinus. When there's tumor by the sinus, it's hard to remove that. It can be unsafe to remove that with surgery. It's okay to do with radiation. So we're able to treat that tumor. So he received radiation to this residual area of tumor that had been growing after his surgery, and it did an excellent job to control it. In the bottom left, that's a vestibular adenoma. So it's a tumor kind of by the hearing apparatus. It's causing imbalance hearing issues for a patient. It was growing on scan slowly. Treated that with CyberKnife radiation, and also controlling the tumor, doing very well. Okay, it's just some examples of non-tumors that we treat. These are CyberKnife. So up here, top left, this was a patient who had refractory facial pain. So he had excruciating pain on the right side of his face, on many medications causing side effects. He was a very high functioning individual, had a very demanding job, and it was getting in the way of his ability to do his job. He was also still having pain despite the medications. So we treated his trigeminal nerve. So he had what's called trigeminal neuralgia. And we treated his trigeminal nerve with a very high dose of radiation. So it's about 3 millimeter target. We are able to give a super high dose, have a safe amount of dose away from his brainstem. And he had an excellent pain response within a week and has continued to have pain response and be off his medications. Bottom left, this is a vascular lesion. It's called an AVM. So these can bleed and be devastating. A lot of times these patients get surgery, but if they can't get surgery because they're not a good surgical candidate, it's in a bad, tricky area, we'll do radiation. Give a very high dose. So this patient received radiation on the CyberKnife and 3 years later had resolution of the AVM. Oftentimes it's best for these smaller AVMs, but we treat the very big ones that can't go to surgery too. And then this right image, this was a patient who had a very bad tremor of his hands, and it was most impactful for his right hand. So he was right hand dominant. So we gave a very high dose of radiation with the CyberKnife to a pinpoint area of his thalamus, certain part of his thalamus, and his tremor is gone on the right hand. We don't really treat the other hand. We're kind of, right now, for the most part, we treat one hand, but it's a very promising treatment for patients who can't get other types of treatment for their tremor. So anyways, that's just to kind of give some context of things that we do treat. And finally, some plans for patients who had pituitary adenomas. These are actually both Dr. JFM's patients. And I think it ties in nicely to his talk as well. So, I mentioned the patient with the meningioma and tumor by the sinus, and it's unsafe to remove that tumor that gets adherent on the sinus for the surgeons, but we can treat with radiation. And Dr. JFM went through the challenges when pituitary tumors are involving the cavernous sinus. So similar challenges in that respect. And so the top left patient, this one here, so this is the coronal image. So this is again kind of similar to the ones in Dr. JFM's talks where you're looking face on to the patient. This red outline is the optic chiasm, the optic structures for vision. So with radiation, we try to keep that dose below a certain number to make sure that the plan is safe for CyberKnife. So she had surgery to decompress and to provide good space. She also had a fat graft placed to protect the pituitary. And there was residual tumor in the cavernous sinus, which cannot be safely removed with surgery. She also had functional pituitary tumor. So she had symptoms from that aspect. So we radiated this residual tumor with CyberKnife. And just a comment, I guess some people like the nuances of the radiation dosing. If you're not as interested, you don't have to listen to this part, but this is treated to 2,500 centigrade, that's 25 gray. So when we prescribe radiation treatments, it's to a certain dose, which is a gray. Like with a medication, you prescribe a dose. And this is in a single treatment. So a single fraction means a treatment. In contrast, this is another patient, left cavernous sinus. And this was residual pituitary adenoma that had been growing on scans. So this one was treated, but to a lower dose. It was non-functioning. So this is 18 gray. So we actually treat the non-functioning, meaning the non-hormone secretory tumors, to a lower dose than the functioning or hormone secretory ones. And I'll explain that a little bit more on this slide. Okay, so radiation pros and cons for pituitary tumors. As was mentioned, we're usually a last resort. And that being said, the radiation can be very effective, oftentimes because working with the surgeon, they can remove much of the tumor, they can debulk, and they can provide us a very focal, well-defined target. And oftentimes we can treat with the CyberKnife radiation, which might be more optimal. Upsides of radiation, it's non-invasive, well-tolerated, fairly low side effects. There's no activity restrictions. So you're not asked, it's not like you have to be in bed or you can't go to work or you can't do any of these things. I had a patient ask me before if I could give her activity restrictions because she didn't want to do any house chores and she didn't want to go to work. And I said, okay, I think I'm okay with that, but you can do all those things. It is effective. So 80 to 90% chances of tumor control. It does depend though on the subtype of the pituitary adenoma. Certain pituitary adenomas are more radiation resistant while others are more radiation sensitive. If we're also trying to control for abnormal hormone secretion, again, you have to give a higher dose. So I indicate here there's a difference between tumor growth and hormone control. Sometimes it's actually quite easy for us, especially with a focal target, to get tumor growth control, meaning this tumor is not going to grow on serial MRI scans to control the tumor in that respect. But then the second thing is, have you controlled its abnormal hormone secretion? So it requires a higher dose to stun those cells enough that they don't secrete those abnormal hormones. So there is a difference in terms of the tumor control that we're going for with radiation. The downsides, really, I can summarize it as it takes time to work. Radiation is not immediate, it's not surgery. So, the upside is it's non-invasive, patients don't need anesthesia, there's no risks really, at the time of the procedure, but it really takes time to work. These are often benign, slow-growing tumors. They often don't shrink much. So patients do not come to us for decompression of a big tumor. That is not appropriate. It goes to surgery. Hormones, abnormal hormone secretion, that can take years to normalize for that reason. And then permanent side effects, if they happen, can take years to manifest, like lower pituitary function. Again, the fat pad is incredibly helpful to lower the dose to the pituitary. So this is a lower likelihood. And then vision changes, again, because of these vision nerves that are nearby. It's very rare to cause severe side effects like with vision, as long as we obey certain constraints and have a safe plan. So when do we use radiation? Dr. Chang had started with this in her talk. Not every pituitary adenoma needs treatment. Fairly common benign tumors affects about 15% of people. I think she had like 10% in her talk. It just depends on what studies you look at with the postmortem and MRI studies. But it's a fairly common benign tumor. Not every tumor needs treatment. We treat tumors that are causing symptoms either from big size. So again, often causing vision symptoms because of that chiasm optic nerves above, or if they're growing and about to cause symptoms. or for patients who have abnormal hormone secretion. So the secretory or functional tumors that Dr. Chang was talking more about. Surgery is often first line for big tumors causing symptoms like vision disturbance, like the imaging you see with the big tumors that are pressing up the optic structures, or certain secretory tumors, prolactinomas, those are causing Cushing's, acromegaly, et cetera. And it may be curable with surgery alone. You saw these incredible techniques that, Dr. JFM has pioneered in all these cases that he showed. Medications are often effective for hormone secreting tumors like prolactinomas that Dr. Chang had in her slides, like that impressive shrinkage of that very large prolactinoma tumor, oftentimes responds incredibly quickly and well to medication. So this is where we come in. Again, last resort, but it can be very effective. So tumors that would require surgery, but the patient can't get it, super high risk, either because of the patient's characteristics that make them high risk for a surgery or the surgery itself. Patient does not tolerate medical management and surgery is not indicated, or more commonly, especially here, residual tumor that cannot be safely removed after surgery, i.e. by the carotid cavernous sinus, and especially if hormones are still abnormal or the residual is growing. Okay, so a little bit more on radiation. Much of the radiation we do in radiation oncology is external beam radiation, it's EBRT. That is radiation that's delivered from the outside in. So it's delivered by a machine from outside to inside the patient, exactly where we want it to go. This is in contrast to internal radiation or brachytherapy. So you might know somebody who, especially if they had a prostate cancer, certain gynecological cancers like cervical or endometrial cancer, they might have received an internal radiation treatment. So that one is a semi-invasive procedure. It's almost like an OR procedure. So again, just kind of to distinguish them, we're talking about external beam radiation, which is the more common type of radiation we do. It's delivered Monday through Friday, typically as 1 hour outpatient appointments. It's completely outpatient. And it can be 1 to 5 days. So typically this is CyberKnife SRS, days meaning fractions or treatments, or 5 to 6 weeks. So this is on our standard machine called the LINAC or the linear accelerator. Just for nuance, if you're interested, CyberKnife is a LINAC, but it's a robotic LINAC, and it has some differences from that. But for the purpose of the talk, when I say LINAC, I'm just saying a standard top of the line radiation machine that we use nowadays to give the fractionated radiation, the protracted radiation, versus CyberKnife SRS, meaning the very focal high dose radiation, usually over 1 to 5 days. How do we deliver the EBRT radiation? There's a few machines to choose from depending on the clinical situation. Again, sometimes one machine is better than the other. So LINAC, this is usually a true beam machine. So you might see this in radiation oncologist notes, or if you know somebody who's had radiation treatment, oftentimes it's the true beam machine. And this is photons. CyberKnife, which again is actually a LINAC, but it's a robotic arm LINAC, very precise, and has real-time imaging during the treatment to be very precise. So I'll talk more about that on the next slide. That is also photons. Stanford will have protons next year. Protons has its benefits in certain clinical situations. There are pros and cons to protons. They're probably known more in the pediatric realm for certain side effects that they might be able to spare, because you can spare more of the normal brain tissue, for example. But again, there are pros and cons to protons, and not every case makes sense to be on CyberKnife or on protons. Just for people who might be engineers or into the physics of it, the difference between protons, so that's the blue here, and photons, which is also known as X-rays, so that's the orange, is their dose deposition. So in some cases, this dose deposition curve of protons is better. So it deposits much of its dose to tumor, and then immediately after that tumor, the dose drops almost zero. There are some cases where that would be unsafe. So if there's certain structures that you are trying to spare and it's directly touching the tumor, that actually would be unsafe. If the brainstem was right there, the chiasm was right there, right next to the tumor, and you had a little uncertainty, you might actually deposit all that dose in those structures. So again, it's just to say, I sometimes have patients ask me like they want protons, and I tell them it actually doesn't make sense in this geometry to do protons. Okay, so a little bit more about CyberKnife, which is kind of our star machine at Stanford. There's videos on YouTube that I made with our patient education team. Again, I'm very involved in patient education in the department. It's one of my major interests. Patients, when they come to me for CyberKnife consultation, I have them watch the videos first. If you are interested, if you go to YouTube and just type CyberKnife, Stanford CyberKnife, it will pop up as 3 short videos and explains the process. Here's just a video showing the CyberKnife machine from Accuray. So a patient lies on the table, they have a mask that's holding the head to the table. So it's a form of immobilization, so the head's not moving around. So this patient would be wearing a mask during the actual treatment process. Most of my patients just fall asleep. You listen to music, the machine kind of just does everything while the therapist monitors. And what makes it a robotic LINAC is it's kind of moving around. It can go anywhere. So there's all these degrees of freedom. It can go anywhere. It comes close and never touches. What allows it to be super precise is, maybe I'll just pause it. There are imagers mounted on the ceiling of the treatment vault. And every couple seconds, it's taking x-rays. So like this, it's taking x-rays. And if the facial anatomy, so kind of this white and versus gray here, do you see how it's a very detailed type of anatomy along this bone. So if it's off by just a little bit, even under a millimeter, the machine's going to make adjustments. It's going to track, it's going to follow. So it's using the bony facial anatomy of these x-rays that are being taken every couple seconds. So that's what allows it that precision. I get asked this all the time in consultations. Is CyberKnife SRS better than LINAC? In certain situations, it makes sense. It's very focal, well-defined tumor. You can safely get the dose in within 1 to 5 high-dose treatments. Then you can have faster tumor control, faster hormone normalization, lower dose to the brain, potentially lower side effects. But in some cases, it's not appropriate because it would not be safe, or we actually want to be more comprehensive with the radiation plan. If the surgeon told me, even though it's not seen on imaging, I'm concerned there's some tumor still by the optic structures. If I have multiple areas of concern from the surgeon, that especially if I can't see on imaging, I'm going to want to cover all of that. And it's not going to be safe to treat that with a high dose ablative radiation. It's not going to make sense to do that. Surgery before radiation can be great to make a tumor smaller so it's eligible for CyberKnife SRS and potentially more effective, like what Dr. JFM was saying. So oftentimes we collaborate with our surgical colleagues and to place a fat graft to protect the pituitary function, to provide some space because the pituitary gland is very radiation sensitive. So here's just an example of a patient who had a large pituitary adenoma, had surgeries, and this patient was not suitable for CyberKnife treatments. It's too big. This blue X structure here, that's the optic chiasm that we talk so much about that controls vision. It's well within the high dose radiation field. So this would be safe on our standard radiation machine. Over a 5-6 week radiation course, it would not be safe to give that high dose over 1 to 5 days. We would cause vision blindness. Is CyberKnife better than Gamma Knife? So UCSF uses Gamma Knife for their brain tumor treatments and non-tumor treatments like tremor, et cetera. Here at Stanford, we obviously use CyberKnife. And we debate with each other, kind of in jest that one is better than the other, even though I think they know that CyberKnife is slightly better. But in truth, like they're kind of the same. So I tell patients, like if they're coming from afar and they have a Gamma Knife, I usually tell them it's not really the machine. Like Gamma Knife and CyberKnife, it's potato, it's Lamborghini versus Ferrari. Again, you can pick whichever one you preferentially like, but they're both excellent tools to deliver a high dose ablative radiation. And actually probably more important, it's just going to somebody who does a lot of these. So at Stanford, we have a streamlined workflow. CyberKnife is our highest volume machine. It is treating patients from 7 a.m. to like late in the evening. So we have a robust workflow. We're very familiar with these types of tumors and non-tumors. So we're very comfortable with treating these. And then just some slight differences. So the Gamma Knife, it's historically used a frame that gets screwed. So it is somewhat invasive procedure. It's screwed and it allows for stereotactic coordinates to know exactly where to treat. CyberKnife uses a mask, so non-invasive. We don't have to add any margin. Nowadays, actually, a lot of Gamma Knife facilities are starting to move towards using a mask because they acknowledge like putting screws is not ideal. But they actually have to add a tiny margin when they usually have to add a tiny margin, which is a 1 millimeter. So that's where a lot of the argument comes in that actually CyberKnife is better because we don't add it. So anyways, a lot of a lot of debate, but ultimately it makes no difference. Just go somewhere that they have a workflow and they're very comfortable treating. So how does radiation kill tumors? Ionizing radiation will damage DNA of the tumors and it leads to cell death. But this takes months to years. This is why, again, radiation takes time to work. Essentially, as the tumor divides, that's when the radiation starts killing the DNA. So for a benign tumor that's growing super slow, that means it's taking longer for the radiation to work. So that's why we have to follow patients for years to see if radiation work, also to follow for late side effects like the nerves that control vision, eye movement, pituitary function. And the goal is to see that the tumor is not growing on those MRI scans. I always tell my patients, your benign tumor is not going to disappear. That would be really weird. Actually, we don't want to see that because it grows slow. It's slow to respond and usually just kind of sits there. So I had a patient liken it to like a snail. And if the snail dies, then its shell sits there. So I've been using that. So it's essentially just like the snail shell. So if a benign tumor disappears, that would be really atypical. So I just emphasize that to patients. Stability is good. Stability is what we want. Some mild shrinkage is great to see, but we don't have to see that. And then again, hormones can take years to improve, average about 2 to 5 years. How does it not kill healthy cells? So these are just pictures that come from the CyberKnife patient videos that I shared that are on YouTube. So it's because there's careful steps with radiation planning. First, the patient gets a simulation. It simulates treatment. So that's a CT scan, typically an MRI scan. If we need a more updated imaging, high resolution, we actually fuse them together. That's what allows us to delineate what we're treating and spare what we want to spare. Patients have a personalized mask. So it's kind of floppy, warm mask that then hardens the shape of the patient's head. They can breathe, see, and hear through it. Then the radiation oncologist works with the neurosurgeon to draw out the tumor based on CT, MRI, and surgical findings. This is why it's critical for us to collaborate with neurosurgery because sometimes things are not seen on the MRI scan that we need to know. There's certain areas that are more at risk. It can be sometimes difficult to understand MRI scan after surgery. We also draw out normal structures we want to protect, optic nerves, normal pituitary brainstem. The radiation oncologist then prescribes a radiation dose to the tumor and puts limits for those normal structures like the optic chiasm. We then hand it off to the radiation planners. So these are physics and dosimetry. It takes a few days to create a plan that meets all those requests. There's oftentimes some back and forth. I review the plan. Can you change this? Can you get closer to my request? And then eventually, once we have the best plan, I approve it. It's ready for QA by physics, and then we deliver. During treatment, don't feel anything, no pain, burning. Sometimes patients see blue flashes of light when we treat by the brain. It's just an innocuous, benign interaction with the retina from the radiation. It's not causing any damage. And then during treatment, if you look closely, these are like the X-ray imaging that's being done every couple of seconds. And this is one of our physicists kind of monitoring. But the robotic machine really takes everything away, and then it's just being monitored very closely. So very straightforward process. And then finally, follow up. We obtain MRI scans every year. We ensure the tumor's not growing, check hormone labs. We usually hold certain hormone medications a few weeks to months before radiation. Might help with faster hormone normalization, and consider restarting a few weeks to months after radiation is done. And neuroendocrinology is obviously very helpful for the above. Okay, thank you. I assume I don't get a mini Q&A. I'm just kidding.
Okay, so I know we are running a little bit behind, but I do want to give some time for you all to take a break and just like to stretch your legs. So I think we can resume our sessions at 11. I know that we have a few questions. So yeah, feel free to get up and walk around. But I know we do have a few, and the restrooms are right outside, out this door. So you can either go out of this front exit to the left or out this exit here. But there are a few questions in the chat actually for Dr. Rahimy. I don't know if you, Dr. Rahimy, if you'd be able to answer.
Dr. Rahimy, yeah, people have a break. Do you mind going to the mic so that they can hear you? I'm going to read them to you. Yeah. Okay, so these are questions from specific attendees for Dr. Rahimy. Okay. Sorry. Dr. Rahimy, will Stanford's new proton center have flash proton?
Oh, sorry. Can you say that again?
Yeah. One of the questions, will Stanford's new proton center have flash proton?
Oh, yeah. So we have, with the development of flash therapy, which is giving very high dose of radiation very quickly. So there's thought to be certain radiobiological benefits of that. I think that it's going to be a while before we combine those two, because even the proton workflow is going to take some time. But maybe at some point they'll be combined. We're not even using flash therapy clinically yet, but there's a lot of interest and investigation. Dr. Bill Liu's one of the main radiation oncologists who's working on that. But potentially, I like that question.
And then the second question from the Zoom chat is, what is a safe age for pediatric treatment with radiation? In this case, for craniopharyngioma, is proton radiation advantageous for pediatric craniopharyngioma? And if so, why versus other types of radiation?
Oh yeah, great question. So, I mean, we have a pediatric radiation oncologist. We do treat children, very young kids. Obviously, in these situations, it's usually last resort to use radiation, but can be very effective. For craniopharyngiomas, oftentimes surgery. Sometimes they'll have a mutation. They can get certain medication therapy like BRAF/MEK. Radiation can be very effective though. And then typically if it's recommended, it is with proton therapy because there can be benefits to spare much of the normal brain. For patients who can't, right now we don't have protons, we will have it. But for example, at Stanford, for patients who can't get protons, like they can't travel, it can take a lot of resources to uproot and go somewhere and get radiation somewhere else. We actually use, not to make it more confusing, we'll use our CyberKnife machine and we will treat fractionated, meaning over several weeks. We'll use the CyberKnife machine to do that. And we use it to try to create or replicate the dosimetry of protons. We create like this kind of ball and try to spare a lot of the brain. So there are alternatives, but typically protons is preferred for a lot of pediatric tumors that have the optimal geometry when we have to treat them.
Thank you. And then the third question from the Zoom chat is, in terms of conventional fractionated radiation therapy and stereotactic radiosurgery, what factors do you take into consideration that may exclude a patient from being a candidate for SRS?
Yeah, I would say the main thing is the target. So again, if it's very focal, well-defined, I have some space for my optic structures, then I will try to do CyberKnife. You can spare a lot of the normal brain. Now, the big concern when you're around this area, especially a post-operative patient, this is why we have great collaboration with our neurosurgeons. If there was concern that there is other areas of disease, and I just radiate something that I see on the MRI scan, but there was actually other residual disease that you can't see on a scan, let's say by the optics. And several years later, the area I treat looks good, but now there's tumor come back by the optic structures. I can't come back and radiate. I already used up my optic structure dose. It's not safe. Now what can the patient do? Usually surgery is incredibly difficult to do in that situation. So if there's concerns with the surgeon, that there's tumor around the optics, it's multifocal, it's not a great, well-delineated target, I don't want to give a treatment that's not going to be effective for tumor control and potentially burns my bridge to come and treat later if tumor were to come back. But much of the time, it is a very focal target. And then we're safe with our optic structures and we are able to do the CyberKnife treatment.
Great. Thanks, Dr. Rahimy.
Yeah.
So any other questions we'll ask at the next break session. We'll take a break for now. Thank
Cool.
you.
Great questions.
And I don't know why I never saw it. Oh, all right. So I wanted to show you some of my early pictures. That first picture is me in high school, 95. I don't really see it in that picture. I think people with Cushing's, once you get diagnosed, kind of look back and you're like, yeah, I see it in that picture. And for me, that kind of starts with that 2009 photo. Between high school and that 2009 photo, I'm just not a big fan of pictures being taken. I'm fine with it now, but back then it just sort of, every time I saw a picture of myself, it just didn't feel right. And it's never really felt right. And I think that's also pretty classic for Cushing's people. You just don't feel right in your body until you get the diagnosis and treatment. So I was definitely on that role. I see it in that picture. I think you guys probably can too, especially if you've had Cushing's. In 2010, I joined a thing at my gym. It was a weight loss challenge, and I really worked really hard. I didn't want to, but I was like, I'm going to mind over matter. Let's see what I can do. Because I weighed 320, I believe. And that was just really kind of crazy. I had finished culinary school and had a baby, but it was just too much. So I was like, let me see what I can do. And so I lost 35 pounds in 6 or 7 weeks. And so that picture is immediately after that weight loss. So I felt very proud of that. I could see my jawline and stuff, but it quickly came back on. I mean, that was like a very abnormal, like eating and exercise period and pattern for me. So I had a little bit of success, but it came right back on. As you can see in 2011, that's like full Cushing's face to me. And so end of 2011 is when I finally started admitting something was going on. It wasn't just, normal, I don't know, normal womanness. It wasn't just, holiday eating or something like that. And so 2012 in summer, I was diagnosed, but I continued a testing pattern. Still don't really, thinking about it from this point of view, I don't think it would take that long today, but it just did for some reason. So in October, I just was having a really bad day. And I was like, I need to just document what my body looks like right now because it hurt. My stomach just felt like it was going to burst. I just ate something small and it just this feeling. And so I took that picture on the bottom left side, the one next to it with the eyes. That was also that same day. I used to get eye infections all the time. And also, I like to point out, like my eyebrows the first time around were nearly black and they're so thick. Like those were not my normal eyebrows. And then I don't want to spoil the surprise, but I had a recurrence. The second time around, it did something completely different. So that picture's on the next slide. But my friend had gotten engaged 4 years in 2008. And so she was preparing for her wedding. It was gonna be a big, expensive thing. And when she showed us the color that the dresses that we were gonna have to wear, we were just like, great, that's so ugly. And this picture looks really great. I like green a lot, but it's like more of a khaki color. And then as I started gaining the weight and got sick, I was like, oh my God, I'm gonna have to wear that dress. And I ended up getting like the cover thing. At first I tried not to be in the wedding and then she wouldn't let me not be in it. And so I got the cover, but still that was a bad day. I was drunk. Like I was drunk in that picture. I was like, I cannot get up here sober and stand in front of people and look like this. So had a surgery, wasn't successful, had another one. They removed my pituitary gland in that second one because it just wasn't clear. Like you saw in these pictures, there's invasion of the everything in there. It's not just like a cute little pea that you just go in and pull out and everybody's great. It's sloppy. And so my surgeon there is Dr. Oyosiku. He's at UNC Chapel Hill now. He did the best he could. I gave him permission to remove my pituitary because that for me was better than bilateral adrenalectomy. And my cortisol still went up after that one. So I had this random remission and nobody could really figure it out like a few months after that second surgery. And so, I don't know, we were just like, whatever, let's see what happens. So slightly less than 3 years later, I recurred for sure. Gained 30 pounds in a month. So I was not a candidate for surgery. I did radiation. I think it's a stereotactic version. I came in every day for 6 weeks. And so eyebrows number 2, in 2017, you can see they're gone. Like there was a few little strands, but they were just like blonde or like clear. I don't know. But I think we moved fast enough that time. I also was already hypopituitary from my first surgery. I'd already kind of gotten used to replacing some of my hormones. So the second time around, I also took a medication to control the cortisol while I was waiting for the radiation to work. And it pretty much kind of just brought me back to normal. I went on like a mental health trip to Cuba that year, which is that third picture. I just got on a motorbike in the middle of nowhere and just like took off and just really, I don't know. That was a good trip for me because I wasn't feeling very happy. I was very miserable, honestly. I just had constant suicidal ideation. Not that I was going to act on it, but it just wouldn't get out of my mind. That second time around, my marriage was also coming to an end. So it was a very stressful time. So 2018, by that point, I was feeling better. I felt like I was looking different. I had more energy. I just felt like it's probably starting to work. I came off that cortisol controlling med because it was controlling it fine. At that point, the radiation started to work. Another year, 2019, looking even better. Again, there's me with Dr. Yosiku again at a conference we did. Oops, oh no, what's happening? I'm trying to go back to the other picture. I do not know what I'm doing. Oh, there we go. So like there's the first picture with him down in 2014. And then there's 2019. Obviously, I like that one much better. And it's just showing that I just started getting better. And I felt like for the first time in a dozen years, I finally was through with Cushing's. And I still feel that way today. I didn't after the first surgeries, just kind of still something in here. And it took a long time to recover. I still got lucky though. I waited till I was completely florid to go for my first test. And so I went looking for a PCOS, a polycystic ovarian syndrome diagnosis. My gynecologist tested all of my hormones and she said, it's not PCOS. You need to go to an endo. It's something pointing to the brain. So with that, you can Google, you can either find acromegaly or Cushing's. And so here we are. So CSRF was started, really, I feel like the origin is 1993 when our founder, Louise Pace, who's pictured here, she gotten her diagnosis, she had surgery for adrenal Cushing's. It was really difficult for her. I think she believed that, I'm gonna have this surgery and just snap out of it, get right back to work. She was like real estate, like businesswoman, and it just did not happen that way. She couldn't get out of bed. She had brain fog, like pain, everything that almost everybody experiences this after Cushing's surgery and treatment that's successful. And so over those 2 years, she was like, what am I going to do about this? She looked for support, couldn't find it online. That's still internet. Actually, I should back up and say that's 1993, 94. I don't think the internet was a thing back then yet. But she was like, she checked with Nord and she checked other places, maybe at Mass General, because she lives in Plymouth. I think that's where she was treated. Just didn't find anything that existed. So she's like, I guess I have to do that. Being the businesswoman that she was, obviously it was going to have to be a 501c3 with a medical advisory board, full bylaws, all that. So she did that. They started with a few people. And then, now 30 years later, we've grown to, our membership is almost 3,000. We've got 7,000 followers on social media. We've got a medical advisory board that's made up of more than 20, like kind of our best doctors and surgeons and 1 or 2 researchers that are around. We've been patient-led since day one. We were able to hire our first part-time employee in 2021. So that was pretty exciting. It was me. And yeah, so 25 years of just kind of being an advocate, starting from just very bare bones, like probably with a typewriter, honestly, 93. I think I was still using a typewriter back then. Up until now, it's like 25 years of just absorbing all that, experiencing it, going to conferences, listening to what doctors are talking about. It got us to the point where we started doing quality of life studies about 5 years ago. We've done 3 really big ones. Each time we do one, it gets more interesting. More of our members and people who are filling them out are finding validation, just like reading a question. You've never told anybody about that experience you had, and here it is on a survey. It can just be validating, just answering that survey, even if nothing else, to see that, yes, this is a real thing that you went through and it was related to Cushing's, whether anybody agrees with you or not, it is. And so those have kind of led us to do a patient registry, which has been many years in the works. So I'm going to lead one of the breakouts later. And so I'll tell you a little bit more about the registry if you're interested in that session and some other stuff about advocacy. And also we can just talk about your Cushing's experience too. I don't want to go too long on registry. It's like a 2-hour chat, but it's just been building on what started in 95, up until now and going forward. It's just pretty impressive. It's very humbling to be part of this machine. So our organization, we've got executive board. We currently have 1 employee, me, but we're hiring. So we're also looking for more board members. So we have a medical advisory board. We have a registry advisory board, since we're building that now with more professional members, but we also have a committee of interested patient members who want to see what the build of the registry is all about and throw in on that as well. We're going to launch a scientific advisory board next year because there's a lot of really interesting work being done in Cushing's right now, looking at things, new concepts, new ideas. There was a mention about PitNet earlier, like that you might hear about PitNet. That's an interesting angle that researchers are going towards about the classification of some pituitary tumors that way. I don't know. It's just interesting to kind of like listen to what the professional people are talking about. I went to a European Congress of Endocrinology earlier this year. There was a debate session and they were actually debating using Dr. Fernandez-Miranda's materials, whether or not to go through that cavernous, or whether to do that particular surgery. And so one was like the pro, yes, of course, it's safe if you're trained and stuff. And the other one was like, no, it's just too risky. And so this entire room full of people at first, when they first were asked on the little questionnaire, do you think that you should take that risk and do that surgery for a patient that otherwise is going to have radiation or bilateral adrenalectomy? And so it wasn't very high, but at the end of the presentation, it was much higher. So I was like, I know that guy. I think I texted you. I was like, look, I'm here. it's just neat to see what they're talking about and be able to translate that for patients to know that there's stuff going on. Because if you go on social media, you're going to get a completely different picture than what the reality of this situation is. I feel like it's positive, it's moving in the right direction. Always too slow, but what can you do? It is moving in the right direction. So we want to bring in some of those fresh concepts. So it's not just kind of like the standard, yep, guidelines, yep, guidelines, yep. We have a, we have a corporate council. We were able to organize our kind of sponsors and supporters into something that helped us further our mission, basically, and hire somebody. That was a big deal to keep the organization going and to just create solid support for it instead of every time, like, it's donations are a huge part of what we do and or how we fund ourselves, but we can't expect patients who are sick and basically spending a lot of their own money to try to get their disease under control to support us whole. So we can talk about that also. I think it's really interesting. Some patient advisory groups for rare diseases are really not anywhere. And like, we have several drugs that are available. We have a corporate council, like we have a rare disease, but we're really advanced in certain ways. Like somehow we're lucky. So we can talk about that. So you're not like, what are you talking about? We're not lucky at all. But, as patients for a rare disease, we are money ahead. I don't know how to put it. We have a patient advisory committee. We have lots of members who want to get involved. And so we meet with them once or twice a month and just talk about all the things that we've got going on and see what kind of piques their interest and where they might want to join us and do some work. And then our membership has always been free. Yeah, you should join. But yeah, it'll always be free as well. And we try to offer everything that we can free to patients. Because again, we know that we're not necessarily in a position to spend more money on support. We're spending a lot on our doctor's appointments and our treatments. Some of CSRF's goals is obviously the peer connection and community. Always need to have that. We try to do something monthly, offer it to everybody that can join. We're realizing now, especially, that we need to do our outreach way beyond endocrinology. There's a lot of progress that seems to be able to be made when we talk about hypercortisolism instead of just Cushing's, because nurse practitioners and all these other people, they might be more familiar with that term. And if that's what gets the screening to happen before somebody makes their way to an expert, endocrinologist 6 months after they make the appointment, that might kind of move the dial in the way towards a faster diagnosis in general, if we have more non-endos doing the screening in the first place and feeling empowered to do that. And so that's really a strong goal of ours right now. We want to support our providers with good materials. We've got a couple questions like, okay, I'm doing this test, but then this doesn't make sense. And I'm like really humbled when we get that question, because I'm like, that's an actual doctor and they're doing what we would hope that they would do. They got snagged. They're not an expert, but they want to do the screening right. And they met us at a conference or something, and then they reached out. Like it's like, there's the payoff for everything. Sometimes when we see that kind of thing happen. Global connections are really important because there's patients all over the world, not just here. There's issues with equity, access. We all have the internet, and we have access to meetings like this, and we're able to get in a car and drive to our appointment. And it's not like that everywhere. There's places where there's cultural and societal things that keep people from being able to go to the doctor or being comfortable going to the doctor and asking for any sort of diagnosis, or there's still beliefs, Cushing's just too rare. Our community just doesn't get that. So there's lots of work to do in that way, and also strengths to be found when we partner with our international peers, because we can learn from them too. So we've been really lucky to make some good connections, and we look forward to making more. Having effective tools for the journey, like something that's actually really usable, like, all right, I read this, I followed it, and it gave me a different result than what I just keep getting. So there's lots of 101 information out there, really good information. And so we try to look beyond that. What more can we give to people visiting our website, whether they join or not as a member, just so that they have something that's just really touches them and they feel like, yes, this is what, something I've been looking for, or just more than like all the same stuff that we find. So that's definitely one of our goals. And then always making sure that our data has got integrity, that we can show where it came from. Part of our registry is trying to figure out how to effectively verify an enrollment. Some doctors or researchers only need to see stuff from people who can have their their whole diagnosis and treatment verified through electronic health records. And there's some that they might not be able to do that. They maybe had their surgery 30 years ago and they weren't on electronic health records back then. We can still include them in there. So having good committees and boards that support us and look over everything that we do to make sure also that we're sending out stuff that's true and not just putting stuff down that's opinion or something and then getting it wrong and kind of getting a little bit embarrassed about that. So I love that Ali was up there earlier because this is also an Ali slide. We met Ali before he ever made his way here. He made his way first to the US and was given options that didn't make sense to him. And like you said, he was just like, I'm not having any of that. He spent the 2 weeks of quarantine. This is during the pandemic. He was just did all of his research. He found you. It wasn't even like he had they had a family friend here who was a neurosurgeon, but he just had so much determination to get the right treatment for him. And he came last year, we had a conference and he came and presented at that. I think he's a sophomore, junior or senior in college now. And yes, he still wants to be a neurosurgeon. I'm doing it again. But these are just some of the cool things that we've done that I just feel really proud about. The registry obviously is a big one. It's a slightly older slide, but because it had Ali on it, I wanted to include it. But we've done some posters for professional conferences. We've done presentations. Just feels really good to have people listen and then ask questions afterwards and to take it seriously and also give us advice that we can use and offer to collaborate. And one moment that was really impactful for me, we had a couple of men on a support call once, and one of them was having a hard time with his hydrocortisone dosing. And so one of the other men was like, hey, let's just connect after the call. And so after a while, I got this email and basically he just said, he'd been having such a hard time with that hydrocortisone dosing. He had not been given like really individualized advice from his doctor. So he was ending the day completely miserable, crashed, unable to spend time with his family. And he'd wake up feeling like death and just sort of like, why bother? Like, why bother? Until he got that dosing in the morning. And then he was so wired because like that dose he turned out to be for him, it was too much. So his dosing was bad, but his doctor was just like, just do the 2 dosing and you'll be fine. He talked to this other male patient, and I think the man-to-man connection was also very helpful. He helped him figure it out. He's like, my life is like completely changed. And all it was just this one conversation, you know, just to talk to somebody else who could directly connect with what I'm talking about and help me. And so he actually lowered his total dose, but felt completely better because he was taking his dose at different times. So all we did was just like schedule a call, but they did all that work themselves. And so that feels really good to see that type of thing. We've got really great opportunities to collaborate more now than ever, but some things we've done in the past. We did a conference last year with Adrenal Insufficiency United. We did a session at ECE, or European Congress of Endocrinology, a couple of years ago with a really great doctor. They offer patient organizations the opportunity to just lead a session with an audience. We can record it if we want to. They really support the patient advocacy organizations. There's some cool papers that we've helped with like patient surveys about quality of life going back almost 10 years at this point. We've got a lot of really good ongoing projects. So we've got a monthly Zoom support call for anyone around the world. We have the Patient Advisory Committee. We have a big conference every other year. Our next one will be next November in Phoenix. So save the date for that. We have a big newsletter that we send out twice a year. And we have an e-newsletter that we send out once a month with kind of like registry updates and just ongoing information. We do conferences. We've got coming up, we are building a memorial scholarship. We had a volunteer who passed away from adrenal insufficiency when she was sick a few years ago. So it will be kind of a memorial scholarship for her. And we're also going to start a research funding arm that will go kind of hand in hand with our registry. So hopefully people will be able to help fund certain types of research. So we'll also use the data in our registry. So that's really exciting. And also obviously the registry, which is launching next year. So I look forward to talking to some of you in the breakout session, but if you need to reach out for any reason at any time, you can reach me at my email, leslie@csrf.net. Also, I brought a bunch of copies of our latest newsletter. They're outside on the table if you want to grab 1 or even 2. And also we have some cool stickers that we've made, so feel free to grab those as well. So thank you very much.
Thank you, Leslie. That was great. Next, we have Jill Cisco. As we mentioned before, Jill, she's the president of the acromegaly community. She's done tremendous work in this organization to help patients be heard, be understood. As you all well know, acromegaly is a rare disease that takes many years to be diagnosed, sometimes 10, 15 years until you get to the diagnosis. And there are many struggles that she knows better than anyone, definitely any doctor. So the job he does for you patients is absolutely outstanding. So we are so thankful for that. Thank you for being with us, Jill.
Thank you. I'll go through this quickly because I know that we are short on time, but I want to talk today, a little bit about our organization. I will also go over a brief regarding our therapies, some of the burdens of our therapies. And lastly, I want to go over some of the unmet needs within acromegaly, because I'm hoping that during the breakout session, we can brainstorm and perhaps try to figure some answers to some of these unmet needs that I could take to people to try to implement. We're always open to hearing. You guys are the experts. You're living with this disease. And we want to hear if you can help us, in any way to try to think of answers to get around some of these unmet needs. So, and it's not doing anything.
You're disconnected there.
Yeah.
What have you do then?
There we go. We got it to work. I'll just use that. Okay. So our mission is to provide an emotional and communal support network for people touched by acromegaly. We offer a central location for medical information on issues including surgery, medication, radiation, and post-diagnosis support. Most importantly, we work to provide a network of emotional support for our acromegaly patients, their friends, and their family. We have the popular website, acromegalycommunity.org. One of my most favorite things regarding that is our Faces of Hope, because I want to show patients that you might start out here, but with some work, you can get over here. And it's not easy, but it can be done. And so our patients volunteer their photos, and we put on there for patients to see what successful treatment looks like. And it's, in most of these patients, it's still ongoing treatment. But, when they are compliant, and I just want to show to patients that with work, you can see improvement within acromegaly. Our goals are to raise awareness. We have support and resources for patients and family. We provide advocacy. We advocate for patients' rights, better healthcare access, more research and funding. We connect patients with other patients within the community. We have research support. I help refer patients for clinical trials and such. Within rare disease, companies look for patients to participate in these clinical trials. And we have to come forward and participate, because if we don't come forward, who's going to? We want to help improve the future for patients. And we collaboratively work with everyone within our space. We work with physicians, pharma, and government entities. We've done a lot of work with the FDA. Our support group started in 2005. It was formed as an online support group for patients to discuss their issues. Today, we have over 3,800 patients and caretakers worldwide advocating for each other with acromegaly. And I don't say that number lightly, because we interview each person before we allow them in. We try to provide a protective space. Within the last pandemic, you hear of so many entities that were fighting and going back and forth online. I'm proud to say we didn't have any of that within our group. It was a very, very supportive space. In 2005, Acromegaly Community was founded. In 2009, I started a women's support group because I knew very quickly that I didn't want to talk about my loss of menses or facial hair or some of the issues that you face with acromegaly in front of some of the men. And so in 2010, we became a 501c3 nonprofit organization. In 2011, we hosted our first conference. We had one in 2012, 2014, 2016. In 2019, we combined with the Pituitary Society. And I don't know how many of you know what the Pituitary Society is, but they have about the top 500 pituitary specialists in the world that are members of the Pituitary Society. And we did this to try to help them understand acromegaly better. And it was a nice thing to be able to put the top 500 physicians, and at that time we had about 200 patients that came from worldwide to attend that. I'll never forget Shlomo Melmed, Dr. Shlomo Melmed asked, how many people here have acromegaly? Will you please stand up? And there were hundreds of patients, and there were gasps because they couldn't believe that all these patients came together. But it truly is just to try to make a difference with this disease. In 2020, we expanded our support groups. We have a main support group. We have the women's group. We also have a men's group so that they can talk about issues like testosterone replacement and things that they don't feel comfortable talking about in front of the women. We have our fitness. I truly do believe that as a patient, we still need to stay active. We need to be compliant, and it's hard because when you're living with a pituitary condition, there's so many things coming at you. It's easy to just go into a hole. And so we try to keep our patients active. And we have a family and loved ones group. And the whole reason that our family and loved ones group came about is because we were getting requests from relatives and such, from members. And we would go to the member and ask them, would you like entrance into the, can let's say your mother have entrance into our group? And they would say, no, I don't want them in there. I don't want them to know how much I'm suffering. And so we try to provide a safe place for the family and loved ones to talk with other family and loved ones that can also understand what they're going through. In 2020, we had an Education by the Experts series. In 2021, we were at 3,100 members. In 2021, we also hosted a patient-focused drug development program with the FDA, which was for drug development, patients need to be involved from the very beginning. They need to understand the unmet needs in order to try to fill those needs for patients. And so what we were trying to do was to try to make the FDA understand the patient journey better in order for them to approve medications that would help with that patient journey, help improve the quality of life of patients. In 2022, we hosted a conference in Milpitas, right down the road. And Dr. JFM was one of our renowned speakers. It was very eye-opening at that time to see the difference that his technique makes in the lives of patients. And I am proud that I personally have referred a lot of patients to him to have second and third surgeries. And they're all doing much better since coming to this facility. And I wouldn't personally hesitate to refer anyone to him because of I think he's the best in the US, and I don't say that lightly. In 2023, we started having regional meetings. We had one in Chicago, Denver, and Charlotte. The reason that we're doing regional meetings is because not everyone can travel. And it's a one-day meeting versus a 3-day international meeting. But we really want to provide support to patients, if you can't get there, I don't want any limitations to people being able to get support. Like Leslie's organization, we're completely free. One thing that I realized whenever I was first starting, I heard patients requesting support, and there was at that time an organization that had a book, and it broke my heart because the people would go on to their chat and they would say, you know, ask a simple question. And the person would come back and say, well, have you bought my book? And it was heartbreaking to me. And I thought, how hard would it be for someone just to answer these questions, you know? And so our service is also always free. In 2024, we hosted a meeting with Barrows in Phoenix. And we also had over 200 attendees, but they also did live pituitary surgery. Just to one up, they did live pituitary surgery during the meeting, and they zoomed in and out of the operating room, and he answered questions while it was being done, which was shocking. But you know, he got permission from the patient to do that, but we always try to one up, and I don't know how we're going to one up ourselves on that one. This year we found that although we did a patient-focused drug development program, that the FDA had released new guidance for industry. And there were some things that were shocking within that guidance. They said that patients could be spontaneously cured of acromegaly. They said that our symptoms were non-specific. And so in order to try to address that, I have found that we're going to have to be a thorn in the FDA's side, and I requested a listening session, and we hosted a listening session. And I'm thinking that we're going to have to do that at least every couple years in order to keep our cause fresh within the FDA's mind, because there were some very blatant things that they had wrong regarding this. So acromegaly, the treatment, I just want to go over what the treatment options are. First, there's surgery. Medical therapy. Our treatments are typically treated with somatostatin analogs, growth hormone receptor antagonist, and dopamine agonist. If that's not successful, radiation. You know, I was diagnosed with acromegaly almost 20 years ago, and radiation was recommended to me. And in my specific case, I declined because there was nothing that they could see to target post-surgery, and they wanted to do a broad path. And I have been, you know, dealing with patients enough, even at that time, whenever they had recommended that to me, that typically a broad path of radiation will kill the gland. And so I had declined it. I also, like a lot of people, think that radiation, there are cases that are perfect for radiation, but radiation, in my opinion, is the last resort. And that's just my opinion from what I've seen over the years. You know, even after that, you have to have supportive care, such as the management of comorbidities, the diabetes, hypertension, all the things that go along with acromegaly. Often within acromegaly, we have to have combination therapy. There was a time within my treatment that I had to take multiple acromegaly medications in order to control. And of course, we have follow-up and monitoring. You know, the treatment burdens, our medication costs are typically very high. And that's sometimes why they recommend the radiation rather than the medication. The side effects and tolerability, the complexity of treatment regimens, managing combination or even monotherapy regimens can be challenging due to drug interactions, side effects, and the need for frequent monitoring. You know, on some of them, we have to go in for liver function tests. You know, for acromegaly, you always need to monitor IGF-1 and growth hormone. Within acromegaly, one of the big treatment burdens and one of the things that isn't readily recognized is the psychosocial impact. Up until a few years ago, this wasn't even discussed at all within acromegaly. You know, there's physical changes from this disease, and it can lead to anxiety, depressions, and a lot of people look inward and they don't go out. It's feelings of isolation. For years, I didn't have a current picture on my social media of myself because I didn't want people to look at me and say, oh my gosh, what happened to her? You know, there's a lot of things. Acromegaly comes at you from every single direction, financially, hormonally, physically. And so it has a huge psychosocial impact. The lack of immediate results. People expect to take a pill and expect it to be better the next day. And the picture on the left is me 20 years ago. And I have no doubt, even though I've had ongoing treatment, I've been on medication since 2006 to treat this disease. I believe that I look more now like what I was meant to look like rather than, and I also think that I look younger than what I did in that picture from 20 years ago. Adherence challenges. A lot of our medications are injections, or recently we had an oral medication that was approved. The oral medication has food restrictions. You can't eat anything for 2 hours prior taking a dose and 1 hour after. And you have to take that medication twice a day. So that's 6 hours a day that you're not allowed to do anything that changes the pH of the stomach. With the injectables, a lot of them, they're long needles. You have to go into an office in order to get the injection. It's supposed to be done every 28 days. Some of these companies had actually had nurse programs that are about to be discontinued, which is going to be a huge unmet need for patients. And it's going to be a challenge. I've heard patients tell me that they live 4 hours from their doctor's office. What are they going to do? We've got to come up with ways to get around some of these challenges that we're facing. The need for regular follow-up. Acromegaly isn't something that is just suddenly cured. You'll have to be followed up for the rest of your life. Even with successful surgery, you need to be followed up for the rest of your life to make sure that there's not a reoccurrence. The unmet needs, early diagnosis. If anyone can come up with a way that we can get diagnosis sooner to our patients, please come forward, because we need to find a way to find these tumors while they are at a small microadenoma state and get people the help sooner rather than later. I myself, I had symptoms for 12 years before I was finally diagnosed, and I was told it was all in my head. And I went back to the doctor that said that, and I said, if you knew that I had a pituitary tumor, why didn't you help me? And he didn't give me an answer, but we need to find a way to get patients diagnosed sooner to get the help that they need. Access to specialized care. Many patients live far from centers of excellence. You guys are so lucky, you know, to be close to this area. You know, Stanford is, like I said, I don't hesitate to recommend Stanford to anyone. I've recommended Stanford to people worldwide because of the quality of care that you have here. But it's not like that everywhere in the US. And whenever I first had my surgery, Dr. JFM wasn't practicing then, but I traveled 11 hours in order to just go for my surgery. Comprehensive treatment options. You know, while surgery, medication, and radiation therapy are available, not all patients respond adequately to these treatments. There is a need for more effective therapies, especially those who are resistant, which, like I said, many patients have to do combo therapies, and their quality of life still suffers. Management of comorbidities, patient education and support, long-term monitoring. And please be thinking about these because I want to discuss these during our breakout session. The psychosocial support, research and clinical trials, awareness and advocacy. We just celebrated Acromegaly Awareness Day, November 1st. And that was implemented just to try to get people to recognize acromegaly. You have to know about acromegaly in order to diagnose acromegaly. And we've had Acromegaly Awareness Day for about 10 years now. Personalized treatment. There's a growing need for personalized medicine. They found that whenever the surgeon goes in and removes the tumor, that they can subtype the tumors and they can determine which medicine would be best for the patient to go for first, rather than having to go through several that won't work. There's a lot of unmet needs within acromegaly, and I'd really like to try to tackle them. And if we can come up with any solutions, I am happy to try to voice those to the powers that be to try to enact those things for us. So thank you very much. And I ask on this, you know, why I had my photo on so many of those slides. And it's because you have to recognize acromegaly in order to diagnose acromegaly. And I'm embarrassed about that photo, you know, but if someone can look at that and say, I know someone else that is changed like that, and get them to a doctor, it's worth it every day for me to put out that photo. So thank you very much.
All right. Thank you so much, Leslie and Jill. And we'll work on getting our next presentation set up. And I just also want to mention, actually in a few weeks, we're going to be involved with an acromegaly patient podcast in San Francisco. And so we're looking for patients who might be interested in sharing their journey and their perspective. So if you're interested in that, please come find me and we can discuss the details. I also want to share too that, especially for those who are online and here, that these sessions are being recorded and will be available after our conference today. And so you'll receive links for all of that after our conference, and they will also be uploaded to our YouTube channel as well. All right. So next, I would like to introduce our next speaker, Catherine Jonas. So Catherine Jonas is a licensed marriage and family therapist based in Los Angeles area. She specializes in areas of aging, disability, and end-of-life care, and also has specific expertise in neurocognitive disorders such as dementia and Alzheimer's and Parkinson's, as well as with pituitary disorders. And so we're very fortunate that she's worked with UCLA and Cedars-Sinai to help facilitate pituitary patient support groups. And it's so fortunate to have her here with us today. Thank you.
Thank you very much. Hello, can everybody hear me? Okay. I like to walk around when I present, How's the volume? Okay. So how's everyone's mental health today? Post-conference slides. We won't go there. So I wanted, thank you for introducing me, Doctor. A little bit going back into my education and training, I was raised by a father who was a pathologist. And long ago, he would take my brother and I into the lab, into the morgue, and we'd get up on a chopping block and I'd see all sorts of things and I was fascinated. So I had an early appreciation of medicine and the fascination of the human body. Meanwhile, I had a mom growing up who took care of her mom with a neurocognitive disorder. So my 30-some years in doing this work is working as a psychotherapist for those with chronic illnesses. And primarily anything that's brewing in the brain is really my passion and the work that I do. So, before I move on, mental health. Do you agree, most of you, that, you know, when you think of mental health, I mean, that was really a term long ago that would mean what? What comes to mind with the idea of mental health? Crazy. What else? Anxiety. What about a movie? One Flew Over the Cuckoo's Nest, right? So there's a lot of societal connotations when you think of mental health. Did I just move away? Did it just go away? It'll come back. Simone Biles comes to my mind. Everyone knows who that athlete is. When she had to pull out of one of the Olympics, and she said, due to her mental health. And I thought that was interesting that she used that term and really put that out there. And we were all kind of left with, well, what does that mean? Did she have a nervous breakdown? Like, what's that mean, right? So mental health today is a very new term. Okay. Great. So mental health is a very kind of new term today. Would you agree? More socially accepted. Would you agree? It's not the multiple personality disorders, the schizophrenics, whatever our connotation is. It's somebody with depression, or maybe it's somebody with an adjustment disorder because they were just diagnosed with a pituitary tumor, right? So I think we need to just over time kind of embrace that. So when a physician calls me and says that they'd like to refer a patient to me, patients come to me before surgery. They're anxious about what treatment modality, radiation, surgery. They come to me with a variety of issues. And the first thing I like to do as a psychotherapist is remind them that they are not their diagnosis. Because when you learn about this disorder, it's pretty easy to become engulfed. Would you agree? You're going along life, right? Life is, and you have symptoms, whatever those are. And then all of a sudden, whack, you get this diagnosis. Perhaps at 12 years later, no one's explained to you. It's all in your head. Pretty terrifying, wouldn't you think? Especially because you find out that the pituitary, how many people learned about the pituitary gland in health, 8th grade health class? Did anybody remember where the pituitary gland was? Okay, don't be shy. Most people have to Google it. So you come into my office and you're hit with, what is this? You know, and what we're going to talk about today is the physiological and the psychological aspects are connected, okay? And we're going to talk about coping mechanisms. I'm a big believer in how human species cope, how you get through the day, how you get out of bed in the morning. And it's going to be different for everybody. And the most important thing, if you can leave today knowing that you are an expert, you are your expert, you probably know more than a lot of internists out there about your pituitary disorder. Raise your hands if you're here as a patient. Great. Raise your hand if you're here as a supportive partner. Great. I love seeing the supportive partners because I'm a licensed marriage and family psychotherapist. And we need you to be part of these conferences so that you can get educated as well. So some of the goals, we're going to look at your psychosocial stressors. What are they for you? They're going to be different for you than for me. Psychological stressors. Have you maybe had depression or anxiety way before being having a diagnosis of a pituitary disorder? Has that been kind of a baseline? Or maybe a dysthymic disorder, which I believe everybody in the world has. It's a low-grade depression that you just function fine at. Okay, we all had it during COVID. Some of us still have it. What are your social and occupational challenges? You know, are you turning down events? Are you not going to the wedding or the family reunions because people haven't seen you in a long time? We're going to understand coping. And I'm going to talk to you about a theoretical modality that is often used. It is in my treatment with working with clients that are adjusting to a chronic illness, which is cognitive behavioral theory. So let's talk about psychological challenges. You first are confronted with a diagnosis, or maybe you're confronting a diagnosis that you should have been diagnosed 8 years ago, right? So you have a variety of emotions around that. All of a sudden, you're going through life, and all of a sudden, life is very much disrupted. Would you agree? No one plans to get sick. As human beings, we know we get sick. We know we don't live forever, but we don't plan on this. And we certainly don't plan on something that's as obscure or rare as a pituitary disorder. We may think other things. So how do I incorporate all this information into my life? How am I handling this? How am I handling this incredible news? Do I tell my family? Do I not? Do I tell my new boyfriend? Do I not? Do I tell my kids? What do I tell my mom who has Alzheimer's? All that stuff, right, that I know is going on in your mind when you get when you are faced with this. And looking at what I want you to take away from today is looking at your own self in your interpersonal relationships. Okay? We talked about feelings towards delays in diagnosis. So what about some of the psychological challenges, post-surgery, treatment modalities? How do I deal with medication burdens, side effects, effort, storage? How do I go on a cruise? Do they have refrigerators on cruises? How do I manage all of this? What about breakthrough symptoms, right? I spoke with a client of mine who had acromegaly, had the tumor removed and moved into a deep depression because she thought everything was going to go back to normal. She wasn't educated, perhaps by the medical staff, that was not going to be the case, that this was just one step in the journey towards recovery. But for her, she did a real dive into that. And so we had to work on kind of readjusting and getting her back to an emotional baseline, and then incorporating all this new information that this is now part of my life. I got this. Somebody else got that. I got this, and I've got to figure this out. What's your attitude about it all? Are you angry, disappointed, sad, hopeful? Are you fighting and climbing Mount Everest? Or are you kind of at base camp and not getting out of your sleeping bag? I see some of you tearing up. That tends to happen because I'm going to push some of these questions, because this is the work that you have to do outside the doctor's offices when you're not on the exam table, when you go home. So there's comorbidities to all of this. Mood-related disorders we talk about. Sometimes there's poor concentration, memory issues may come about. I know there's I have a slide on acro fog. Weight gain. No fun for anybody, male or female. Pain, we talk a lot about. Physical changes in appearance. I really want to acknowledge Leslie and Jill for sharing, being vulnerable to share their photos. I thought that's incredibly helpful because we need to see the physical changes in one's body to understand it. What about sex drive, low libido? That's often, we don't talk about sex a lot, but it's a big piece of the work that I do with clients in my practice about how that's affected. And sleep. I'm fascinated by sleep, and I'm a big believer in sleep. It's the very first question I ask. How's your sleep? Are you sleeping? Are you not sleeping? Are you having a hard time falling asleep? Do you wake up too early? Do you having interrupted sleep? If I'm really emotionally stressed on something or there's something going on, I'm always up at like 1:30 in the morning. And then I may go back and then I'm up. That's called interrupted sleep. So according to the CDC, 24-hour sleep deprivation is the same as having a blood alcohol concentration of 0.10. How about that? Anyone ever do an all-nighter? Don't you feel pretty awful the next day? Pretty interesting comparison, isn't it? We're more irritable. We have impaired concentration, memory, increased stress. Sleep deprivation is used as an interrogation torture technique. How about that? They keep you awake, so they break you down. So look at your sleep. And are you practicing good sleep hygiene? What can you do to look at your sleep, and can you make that better? So social and occupational challenges. So as you're embracing all of this in your life, this new news, how is this affecting my relationships with my partner, with my children, with my parents, with my coworkers? Are people believing me? Do people believe me after all these years when everyone said it's in your head, right? Or people have been telling you to take antidepressants or, dealing with headaches, but it's much bigger than that. So as a licensed marriage and family therapist, I swoop in like a hawk because this is not just about the client with acromegaly. This is about the family system. This is about you as a family. How do you manage this? You as a couple, as a dyad. How do you manage this in sickness and health and the commitment that we all hopefully have to one another in our families? I know it's not easy though, right? I have my own family. We know it's not easy. Am I turning down social activities, pulling away from work events? What about financially? Can I still support myself, my family, to my expectations? So I was at a conference recently, and there was a similar slide to this, and it kind of caught my eye. I think it's important that we don't blame everything on, now that I have this pituitary disorder, I can behave like this or that, right? I think that you have to learn who you are. You have to know your baseline personality. But now you've got this new animal that you have to deal with. But how can I be an advocate? How can I improve sleep issues? Can I improve my behavior with my loved one? Things like that are really important. So the role of the psychotherapist, I talk about a systemic approach, a bird's eye view of when I work with families and clients, that this is not just about the identified patient. And really, as a psychotherapist, we like working with patients so we can validate you. So many people with different pituitary disorders don't feel validated in the healthcare system or with physicians or nurses or whatever. And it's really important that people feel validated. So quality of life, what does that mean? Quality of life, very kind of topical term, quality of life. What's that mean to people? Quality of life. there's no right or wrong answers. Anybody have an example of how you're able to live your life, quality of life, right? What you do outside of work, school, teaching, what keeps you going is quality of life, right? People that like to work in the garden, that's quality of life, right? Things that keep you going outside of the mundane things that you have to do. So functional impairment, I really am interested in activities of the daily living. That's major, and that's kind of scientific as far as functioning. Are you able to shower, toilet? Where are you in that level? Those are real kind of dynamic, functioning quality of life issues and functioning. Let's talk a little bit about coping, okay? A topic that I'm very interested in. As you go through these slides, I want you to think about kind of which slide you gravitate to. Maybe there's a couple of them that you may connect with. So we're all coping. Human beings cope, right? We've been doing that forever and ever, and hiding in the cave or going out of the cave and having the tiger chase us, whatever you do. So these are specific efforts which we use to master, tolerate, reduce stressful, right? Cool. So there's 5 main coping mechanisms that I talk about. And the theory is that you can use any of them at any given time to deal with stress. So which one do you use? Fighting spirit. Leslie, Jill, fighting spirits over here. Okay, and guess what? It's contagious, fighting spirit. You want to be around people that have this, that see their illness as a challenge. They're active player in this journey. Anybody heard of denial? And anybody? Okay. Yeah, it's not a river in Egypt. Denial, actually, a lot of experts say, is healthy. It's kind of like when you get this hit and you just like go to this place of like, no way. It cannot be happening to me. No way. It's kind of a safety zone, but you can't live in denial. You're going to get real sick if you live in denial. Okay? You're allowed to go there and be there for a while. Okay? It really can lead into depression, anxiety, maladaptive coping mechanisms. Fatalism. This is kind of an interesting coping mechanism. That's not a big deal. It'll go away. That pain behind my eye, I'm getting the little blurred vision, but it's all right. Okay? Be aware of that. I just can't handle it. I'm giving up. I'm just going to give up. Some people have to go to this place just to kind of get through, right? Anybody anxious, preoccupation? You're on the internet all night and you're on WebMD and you're going crazy. That is not part of good sleep hygiene, right? No blue light. Be mindful of that, okay? Be very careful of this. Find your care provider that you trust and follow their lead. Be very mindful. There's a place for this. Okay, life. There are things we can control. There's things that we cannot. Hopefully you can choose who you need to use as a healthcare provider. If you live in a small town, you may have to work as a team or with family to get you to a state-of-the-art procedural center. You can't do much that you're on this path, that you have this, that you got this, right? That you need treatment. So how do you cope with controllable stressors? Problem solving, decision making, seeking information. That's that fighting spirit that I want you to find yourself in most of the time. Making decisions, being an active player, going into that doctor's office with notes, bringing someone with you who can maybe, if you get the white coat syndrome and you're anxious in front of the doctor, someone who can go with you to take notes. who can be a witness, a historian for you. I want you to have like a little team. Who's your team, right? Like I look at Jill and Leslie, they got Team Jill. They got their supporters, right? Their patients too. What about uncontrollable stressors? Things that life, there's nothing you can do, right? So you've all heard this before. Find ways to breathing exercises, relaxation techniques. Maybe it's mindful exercises. What about music? Music does wonders for the brain. Okay? Music, art. Do you like to write? Free association writing, Dear God boxes, all sorts of things that you can do. Okay? How are we on time? Good? What about triggers? Anybody triggered by like a family member? Anybody? Triggers. How about traffic? Trigger. I see red, only red on my, and I'm not talking politics. Only red, I only see red on the 405 South. Oh my God, I'm already in a horrible mood, right? So we can't control family members. We can't control traffic. Be mindful of triggers around your emotions, around how you react, how you behave. We know a lot about Cushings with an increased cortisol or with acromegaly increase of growth hormone. There's acro rage, there's acro fog. Those are real. For those family members in here, know that those are real. Okay, so be mindful of those as well in learning, as you're learning this kind of disease too. So the theory that most psychotherapists use when dealing with chronic pain, chronic disease processes is cognitive behavioral theory. Cognitive meaning how we, the brain, how we think. Talking about cognition. Behavioral, how we behave, how I show up at a party, how I act to my partner. Okay, that's the idea. And the idea is that the thought comes first, and then the behavior comes last. And then ideally, there's an emotion, and we'll go over this situation of thought, emotion, behavior. The theory states, and this is for everybody in this audience, not just those that have a pituitary disorder. This can work with those that are partners, medical staff. It's a theory that psychotherapists use oftentimes as a treatment modality, that a situation can be fixed. How you think about it is going to affect how you feel about it, will then eventually affect how you react or behave to it. We believe in automatic thoughts. Automatic thoughts that just come so quickly you don't even know where they came from, right? We get this from childhood, right? Those as when children were sponges. So we get this from parents or those that raised us, early teachers, religious authorities. So here's the idea. You have a situation. The doctor's office calls. My initial thought is what? My initial thought is like, uh-oh, why is the doctor calling, right? So what would be the emotion around that? Terror, fear, worry, what's happened? Is this about my blood test that just came back or the MRI I just had? So then the idea is then, why get out of bed in the morning? Why make that phone call that I really need to? Does this make sense to everybody? Breaking it down real simple. The goal is to break down thoughts and dispute the thought. Feelings are not facts, but boy, feelings feel pretty real, right? So rather than talk about positive, I don't like think positive. Don't tell me to think positive, please. If I'm not feeling happy, if I'm in pain, if I have a headache, if I'm feeling depressed, don't tell me to think positive, right? I want you to think rationally versus irrationally, right? I want you to have your boots on the ground. So ask yourself these 3 questions. Are my thoughts based on fact? The doctor's office has called you. I already know it's bad news. How do we know that? Right? We don't know that. Does my thinking this way help me get out of bed? Does it help me take my 2-year-old to daycare? Or does it help me change my mom's diapers because she's got Alzheimer's, right? Hello, right? I don't know what's in your personal lives, but I know you all have responsibilities, don't you? Right? You're getting someone to school, or you're taking someone here or there, or showing up for somebody. And ideally, does the way I think really kind of help me just with my goals? I don't mean lofty goals. I mean getting out of bed. If you've answered no, maybe you think about changing your thought to a situation. Here's the sample slide. You can all read that yourself. How about we change the thought to, I don't know what the news is, but I'm going to be able to handle this no matter what. I don't know how. It's about changing a thought. It takes a lot of practice. I think as human species, we go to like, the tiger is running after us. I'm going to die, right? Challenge the thought. Boots on the ground. Be where your feet are. I can always call Leslie. I can call Jill. You can call Catherine. Who is on your team? If you don't have one, find one. So how do we do this? Repetitively. I'm going to give you a personal example. I've always been a working mom. I love working. I raised a daughter and she saw me as a working mom, but they had these PTA meetings at 10 a.m. on a Tuesday, right? I didn't go. I couldn't go. I had to go to work. I had to be with my patients. I had this automatic thought, I'm a bad mom. I'm a bad mom, right? Be mindful of that. Where did I get that automatic thought from? So I had to work really hard at, I'm not a bad mom, right? My daughter works for a healthcare company today and she's doing fine, right? She's making her own chocolate chip cookies. So common cognitive distortions, watch out for these. We do this all the time, all or nothing thinking. Anybody? All or nothing. All right, common cognitive distortions. If I can't do all the things I used to do, life is not worth living. That's pretty dramatic. Okay. Catastrophizing. Anybody do this? We catastrophize, right? My life is over. No, you're not. Your life is not over. You're going to find ways to cope with this, maybe be of service, may join the acromegaly community or work with Cushings or other organizations. Shoulda, woulda, coulda. I should have gone to the doctor earlier. I didn't want to deal with those headaches. I've been working with a wife who's been really struggling about the fact that she noticed her husband's hands were growing. The wedding ring wasn't fitting any longer, but she didn't say anything. You know, we got to let go of that. We all have stress. I don't know what your stressors are. You know what they are. It's more about managing them, how to cope with them. What are you doing to take care of yourself? Are you having any fun in life? Is there any lightness? What are the things that are giving you quality of life outside of going to doctor's appointments and worrying about labs? And what are those things to really look at building those up? Would you say some of this is about grief and loss? Grief and loss, right? This was not your plan. And I don't know about you, but having taken anything out of my body, and I know a tumor, you want it out as fast as possible, but I don't even like when blood is taken out of me. It feels like a loss. I know that may sound odd, but it is, it's a change in your your being. It's a deep, deep physiological and psychological change. When I first had to get glasses, I went to lens crafters and I cried because I felt old. It was my very first hit, right? Coping with loss is a deeply personal and singular experience. There's no time frame, no pretty packages. Allow yourself to grieve, whatever that looks like, but we can't live in that. Denial, we talked about that a little bit as a common stage, okay? Anger, anybody angry? Yeah, okay, or initially was, or kind of you go in and out of anger about what life has given you in this regard or having to deal with this. Very common, very common. Bargaining is a very common grief and loss theme in that, like, if I could just be better, take this away from me, right? It's very common. Depression is very, very common when dealing with chronic issues. Anhedonia, lack of interest, enjoyment, or pleasure. If you used to always like to sew and you have no desire to sew or knit a scarf this holiday season, that's what you have. And my work is to help you get back to sewing or knitting. Be aware of isolation. It's okay to go within, but be very mindful of not living there too long. And acceptance. Is there anybody that's moved into acceptance? I see Jill, I see some hand, I see, oh, I like this. I have a so-so acceptance. Yeah. I think like acceptance is fluid. I think it moves. I think you may have it one day and then you're angry the next day. Not everything is perfect. I think the more you move into being an expert and an active player in your recovery, you will move closer to being an acceptance and not in fear or shame or anxiety or wherever that comfort mode is for you. So some good books here. I like bibliotherapy. Joyce Rupp, she's fabulous for those that kind of have a Christian Catholic slant to you. Your sorrow is my sorrow. Those that feel more comfortable with Judaism, this is a wonderful book, the Jewish Book of Grief and Healing. And then the third book is just Grief Your Way, You Do You, okay, on grief. Support groups, we've talked about that today as I wrap up here. I don't know how any of us can do this alone. You have to find your team, find your group, find somebody that has that common denominator, that shares your story. And I always like to end on this. This kind of goes back to that cognitive behavioral work. Watch your thoughts. They become your words. Watch your words. They become your actions. Actions become our habits. They become our character. And that is what you leave behind. Thank you very much.
Hi, Catherine. Thank you so much for that talk. Just 2 questions from our audience on the Zoom chat. So one is in regards to a patient who suffered from Cushing's. Her question is, trauma damaging the brain and causing Cushing's. Dr. Robert Sapolsky at Stanford has studied the stress hormone and trauma causing Cushing's. Also, he suggests Cushing's may be reversible. What are Catherine's thoughts on this?
I did not hear a question.
This is from one of our Zoom audience participants. So I'll read it to them. So their question is, trauma damaging the brain and causing Cushing's. Dr. Robert Sapolsky at Stanford has studied the stress hormone and trauma causing Cushing's. Also, he suggests Cushing may be reversible. What are Catherine's thoughts on this?
Oh, interesting comment. I can't speak for that physician and the work that they have done. I can speak to that. I think you have to look at the components of the disease process along with the personality of the person who got the disease or the disorder. So I think you have to look, it's multifaceted. So I think you have to take into effect trauma, the impact of cortisol, and then also the psychosocial stressors or triggers that you're dealing with. Yeah, I don't know if there's I think human beings were constantly growing and changing and activating. And I think that's where the growth is.
And this one's a more general question about cognitive function. How to rebuild and repair, what therapy solutions are available?
Repair and rebuild cognitive function. So my first thing would be to find cognitive activities that are stress-free. So a lot of people will say do crossword puzzles or word searches. That would cause my anxiety to go up. So I'm more right. So I'm more at there's a lot of things that build cognitive, build the kind of cognitive muscle. Find activities that I don't know. It could be doing puzzles, doing art, listening to music. There's a lot of research on looking at those other activities to build cognitive, but it's still so much under research. Just make sure it's pleasant, not you're forcing yourself to do something you don't want to do.
Thank you. And the last question is there any, studies have shown that trauma can shrink the hippocampus and the amygdala swells up. How does this affect the pituitary gland?
That sounds more like a medical doc. Is that anyone want to speak to that?
To our knowledge, it doesn't.
Oh, it doesn't have any, read the question again.
So their question is, how does trauma affect the pituitary gland?
Yeah, interesting. From a psychological standpoint.
Correct.
Okay, well, trauma, in my professional opinion, is going to cause havoc anywhere in the psychological psyche of a human being, depending on, defining whatever the trauma is that you've experienced. So, and I want to make sure I answer this question. And if I don't, I can get back to you on it. I think part of trauma is you have to get some very good psychotherapy. You have to learn how to really work with strong coping mechanisms, how to do self-care and rebuild from the trauma you've experienced. The damage that it's done to the brain, I'm not sure how to undo.
Great, thank you.
Right. So next we have Dr. Andrew Hoffman. So Dr. Hoffman is a professor of medicine in the Division of Endocrinology, Gerontology, and Metabolism, world-renowned expert in pituitary disorders, particularly with growth hormone research. And so we're very fortunate to have him speak today on hypopituitarism, diagnosis and treatment.
Thanks. What I'd like to do is to talk to you now about some of the ways that we diagnose hypopituitarism and how we treat it. And I hope it'll be useful to you. By hypopituitarism, what we mean is any kind of decrement in the function of the pituitary gland. Okay? It means any of the hormones that the pituitary makes may at some point not be functioning properly, and that will lead to a deficit in health. The main causes of hypopituitarism are pituitary or brain tumors, or the treatment of those tumors, either surgery or radiation. Sometimes there's infection in that area that can also cause it. Less commonly, we see hypopituitarism caused by traumatic brain injury, and occasionally there are some autoimmune diseases that cause it. Now, with some of the new cancer therapies, there are therapies that are called checkpoint inhibitors that are being used very, very commonly right now. If you watch television, you'll hear a lot about a drug called Keytruda. That's one of the examples. And these drugs can also, on occasion, cause hypopituitarism. Again, in this audience who have had a lot of experience with the pituitary gland, I think you know that the pituitary is a very important hormone gland because it directs the function of many other glands in the body. And we'll go over them together. It affects the thyroid gland, which makes thyroid hormone. It affects the adrenal glands, the mammary glands, It has actions on the bone, on the kidney, on the ovaries and the testes, and also on the uterus. So I'm going to go through, I'm going to go through the hormone deficiencies in the order in which they're the most critically important for maintaining health. And the first one that really is exceptionally important is adrenal insufficiency. So the adrenal gland regulates our blood pressure, it regulates our blood sugar, and it keeps both of them in the normal range. It is absolutely necessary to combat stress. And during stressful situations, like an infection, like an operation, our body needs a lot of cortisol, much more than it needs during a regular day. Cortisol is absolutely necessary for life. And it's the only hormone where if you do not take it, you really risk getting into a situation where you can end up with what we call an adrenal crisis. Your blood pressure falls, your temperature goes up, and you can actually die from this. So it's really the most important form of hypopituitarism. The symptoms of developing adrenal insufficiency are weakness, lethargy, a lack of energy. Sometimes there's dizziness, especially when you stand up. Patients are often depressed, and there's often weight loss. We make the diagnosis by getting either an early morning serum cortisol, or as many of you have had, something called a cortrosyn stimulation test. This is a test where we take a pituitary hormone, ACTH, or an analog of that, cortrosyn, and we give you an injection, either intramuscularly or under the skin, and then we measure the cortisol level 30 to 60 minutes afterwards. And that's the most sensitive way of making the diagnosis. The treatment is to give back cortisol or a cortisol-like drug. And we have a number of ways of doing this. And I'm giving you the cookie cutter way of treating it. Everybody needs a personalized approach for cortisol replacement therapy. So the one that we use most is hydrocortisone. Hydrocortisone is just another name for cortisol. Okay, it's the natural hormone. It has a very short half-life, however, and it has to be given at least twice a day for maximal effect. We can also use prednisone, which is an analog, a chemical analog of cortisol. It has a slightly longer half-life, and we can get by with once-a-day therapy in many cases. Similarly, dexamethasone is another analog. It has a very long half-life, and some physicians like to use that for replacement, although I personally do not. Cortisone acetate is an older form of therapy that we rarely use anymore, but it's perfectly effective in most patients. Patients who have adrenal insufficiency should also have their physicians write them a prescription for injectable Solu-Cortef, so that in a state where they're going into an adrenal crisis and they're throwing up and they can't get cortisol or their hydrocortisone to stay down, they need to give themselves an injection of hydrocortisone. And it's also important, I think, for patients who have adrenal insufficiency to get a medical alert bracelet that tells the physicians and the emergency technicians that they do have adrenal insufficiency and need hydrocortisone. It's been my experience, however, that many of the EMTs will not provide the hydrocortisone even with the bracelet. So it's important to have the hydrocortisone available at home and to know how to use it. We monitor therapy by clinical symptoms. There's no blood test that tells us we're giving the right amount of hydrocortisone or whether we're giving it at the right time of day. So your physician needs to ask you questions to try to elicit any symptoms that you have to make sure that we're giving you enough hydrocortisone or prednisone, not too much. Very important that if you are sick, we give you sick day precautions to tell you to double or triple your normal dose of glucocorticoid replacement therapy. Because if you don't, you can get very, very sick, and it gets into a vicious cycle where you can get extraordinarily ill. You need to tell your dentist and your physicians and your surgeons that you have adrenal insufficiency, so they can give you what we call stress doses of hydrocortisone if you're going to be given general anesthesia. And these are doses of hydrocortisone that may be 10 or even 20 times your normal dose of hydrocortisone. So this is a very important form of therapy. It's very important that you don't run out of your therapy. The next most important replacement is thyroid hormone. The thyroid gland controls how our body uses energy, okay? It controls our body temperature. It controls how fast we burn calories. And it really affects everything we do, our breathing, our digestion. Every organ in the body needs thyroid hormone. If we lack thyroid hormone, and this is very common in people who have thyroid disease, but if you have hypopituitarism, you lack the pituitary hormone TSH, which stimulates thyroid production, you'll feel cold and fatigued. You may gain weight. Your body temperature may actually drop a couple of degrees. Constipation and depression are very common, and weight gain is common. We make the diagnosis in patients with pituitary disease who have hypothyroidism by measuring the serum free T4 level. We do not rely on the TSH level. The TSH level will be low, okay? And we do not use the TSH in making our diagnosis. The treatment is usually quite simple. We give back thyroid hormone. We can usually get by with once a day thyroxine, L-thyroxine, Synthroid or Levothyroid. There are a number of generic preparations. Sometimes we add back the active hormone LT3. Most patients do not need that. And there are some patients who take thyroid extract, like Armour Thyroid, which we generally do not recommend, but it also is an effective treatment for hypothyroidism. Cannot stress how important it is that when we monitor therapy, we measure the free T4 and not the TSH. And if you are on thyroid hormone for hypopituitarism, do not let your primary care provider modulate your thyroid dose, because physicians are taught that the most sensitive test for thyroid disease is the TSH level, and that a high TSH level means that you're hypothyroid, and a low TSH level means that you are hyperthyroid. You have too much thyroid. And that's true for 95% of patients with hypothyroidism, but it is not true for patients with hypopituitarism, where the TSH is always low. And many patients will have their primary care provider try to lower their dose of thyroid hormone replacement because they've measured the TSH. Don't let them do that. Thyroid hormone will increase the metabolism of hydrocortisone. So patients who are already on hydrocortisone may need a higher dose, and patients who have borderline adrenal insufficiency from their hypopituitarism may suddenly become hypoadrenal because of thyroid hormone. And often when we start thyroid hormone for patients who are hypothyroid from their pituitary disease, we also start hydrocortisone at the same time, just to make sure that they don't develop adrenal insufficiency, which, as I mentioned, can be lethal. The next most important one is vasopressin deficiency. Now, vasopressin has two names. One is arginine vasopressin, AVP. The other name is the antidiuretic hormone, ADH. It's essentially, it is exactly the same hormone. It just has two names. And if you lack vasopressin, you end up with diabetes insipidus. The function of vasopressin is to regulate your sodium and water concentrations, to regulate the volume of your blood and your blood pressure. If you lack vasopressin, you will become very thirsty and you'll start to urinate a great deal. And many patients will note that they really crave very cold fluids. You'll frequently urinate throughout the day. And if you are not treating the diabetes insipidus with either drugs or a lot of water, you can end up with a lot of electrolyte abnormalities. You might become confused, and you actually can go into coma. So it's very important that this therapy be treated. We make the diagnosis by measuring a blood test, the serum sodium, and we measure the specific gravity and the osmolality, the concentration of salts in your urine. We can measure vasopressin directly, or we can measure part of the vasopressin prohormone called copeptin. However, this blood test usually takes about a week or two to come back, and it has very little utility in an acute situation or in making the diagnosis. The treatment is desmopressin, or DDAVP. And DDAVP is a synthetic form of vasopressin. It comes in pill form, it comes in a nasal form, and it also comes in forms that we can give intravenously or subcutaneously. We also have to give fluid replacement. We monitor our therapy by measuring the serum sodium, by measuring our fluid intake and urine volume, and by measuring the urine specific gravity and osmolality. It's important when the diagnosis is made that if the individual, if you're very dehydrated, your serum sodium will go up. If you've taken too much of your desmopressin, your serum sodium will go down. And we try to normalize the serum sodium. It's important that we do it in a very cautious and generally very slow rate so that we don't make major changes in the sodium, because this can affect the brain as well. Okay. The pituitary controls the ovary and the testis, so that if you have hypopituitarism, you might have hypogonadism. You might have ovarian or testicular failure. So as you know, the ovaries make estrogen and progesterone and oocytes or eggs, and the testes make testosterone and sperm. The symptoms of hypogonadism in women are menstrual disturbances or complete cessation of menses, decreased libido, pain with intercourse. And in men, they may have decreased libido, erectile dysfunction, and in both sexes, infertility. We make the diagnosis by measuring these hormones. You can measure LH and FSH, estrogen and progesterone, and testosterone. And we can do a semen analysis to measure the sperm count in men. The treatment can be rather complicated, but just sort of as a brief overview, in women, we usually will, depending on their age, will replace the estrogen and perhaps the progesterone. There are patches, there are long-acting preparations that include intramuscular and subcutaneous preparations. For men, we give testosterone, and this can be administered by a gel, by a sort of an from an underarm deodorant kind of gel. There are shots, there are patches, and there are long-lasting pellets that can also be given to replace testosterone. We can talk more about that in the breakout sessions. For infertility, the treatment can be much more complicated. Somebody who does not have LH and FSH secretion occurring in the right way will often become infertile. For men, sometimes we can treat them fairly simply with occasional shots of HCG that will improve the sperm count. For women, it becomes much more complicated because we have to replace both the HCG and the FSH in a very careful, precise pattern to cause normal ovulation. Sometimes we can do this with in vitro fertilization. Sometimes we can get away without doing that, but it becomes a rather complicated form of therapy, and unfortunately a very expensive one that may or may not be covered by insurance. We monitor therapy for the hypogonadism in women by measuring the serum estradiol, and in men, we measure the serum testosterone or the semen analysis. We have to be careful that we get these levels in the right range because estrogen has the risk of causing blood clots. Testosterone can cause an increase in the red blood cell count, and this can also lead to blood clots. So we have to be very careful about that. Next is growth hormone deficiency. Okay? So growth hormone is a very important hormone in childhood. You can't achieve normal height if you don't have growth hormone. And children who are growth hormone deficient will end up only being about 3 or 3.5 feet tall. But after our bones fuse, our pituitaries still make growth hormone. And growth hormone is very important to regulate our body composition. It changes our fat mass, our lean mass, our bone mass. It is very much involved in cardiac function and in psychological functioning and in quality of life. The symptoms of growth hormone deficiency are weakness, fatigue, lack of energy, decreased exercise capacity, and occasionally depressed mood, and patients often report social isolation. We make the diagnosis by doing a growth hormone stimulation test. And this is a test where we give you either an injection of glucagon, a natural hormone made by the pancreas, or by doing an insulin tolerance test, which is something we really don't do very often anymore, where we give you an injection of insulin trying to lower your blood sugar, and that's another way of stimulating growth hormone release. Another test that we use as a screening test, but not as a diagnostic test in most circumstances, is the serum insulin-like growth factor 1, or IGF-1 level. The treatment for growth hormone deficiency is subcutaneous growth hormone. Growth hormone is a big molecule. You cannot take it orally. For about 30 years, we've been treating patients with daily growth hormone injections. Starting last year, we now have the availability of a long-acting growth hormone preparation that can be given once a week. Unfortunately, growth hormone is also an extremely expensive drug. It's covered by most insurance policies, but often the copay can be fairly expensive. We monitor growth hormone treatment by asking about your clinical symptoms. And I have to tell you, we monitor all of our hormone treatments by asking about clinical symptoms, because not everybody needs the same amount of hormone, and people respond differently. And we measure the serum IGF-1 level and try to keep that in the normal range depending on the patient's age. When we start growth hormone, we have to be cognizant that growth hormone will increase the breakdown of both levothyroxine and hydrocortisone. So we may have to adjust the doses of both of those medications once we start growth hormone. When we stop growth hormone in patients once they come into the hospital or when they're pregnant, and then restart it after the pregnancy and after the hospitalization. Prolactin is a hormone that prepares the breast for milk during pregnancy and then continues to keep preparing the breast when the baby is nursing for women. There is no known function of prolactin in men. Men make prolactin, but we don't know what it does. The symptoms of prolactin deficiency in women is they are just unable to lactate. They cannot breastfeed because they're not making any milk. We can make that diagnosis by measuring a blood test, measuring the serum prolactin, but there is no replacement therapy available. So if you're in a situation where you have prolactin deficiency and cannot breastfeed, you'll have to treat the baby with, you have to nurse the baby using formula because there is no way to give you back the prolactin. Okay, the last hormone made by the pituitary is oxytocin. Oxytocin is necessary for milk letdown from the breast, and it stimulates the uterus to contract during parturition, during delivery. It has no known function in men. People have been studying oxytocin in the brain, and you may know it as the love hormone. There's been a lot of controversy as to whether it really, what function it does serve in the brain, but there's a lot of very interesting research going on with it right now. The symptoms of oxytocin deficiency are you have trouble breastfeeding, and you may have trouble going through the delivery. And the diagnosis is purely made on clinical suspicion during the delivery. We don't measure serum oxytocin. During labor and delivery, we often treat patients with oxytocin. Pitressin is the most common brand name, and even women who do not have oxytocin deficiency will sometimes get injections of pitressin to continue the delivery in a safe fashion. We monitor therapy purely by clinical observation. So my take-home messages for you today are that hypopituitarism can be caused by pituitary and brain tumors or by the treatment of those tumors, surgery or radiation therapy. If you've had radiation therapy, the effect on pituitary function may take many years to become manifest. And in our practice at Stanford is that once you've had pituitary radiation, we will follow you on an annual basis for the screening of pituitary tests. I've seen patients who develop hypopituitarism 10 or more years after the radiation therapy. So it requires lifelong follow-up. Thyroid hormone and growth hormone therapies can alter the breakdown of hydrocortisone and other hormones. Most important message for you to get is that hydrocortisone is necessary for life. You must increase your dose during sick days or during surgeries or other major stresses. And it's up to you as the patient to never run out of your drug. And the good news is that with careful clinical follow-up and with I think a knowledgeable team of physicians and nurses, we can replace essentially all pituitary function with synthetic hormones. And therefore, patients with hypopituitarism can live normal, fulfilling lives. Does not decrease your life expectancy. And in most cases, it should not affect things that you want to do in life. So I think it's time for lunch. We may have time for a few questions, however, do we?
Thank you, Dr. Hoffman. So a few questions from the Zoom chat. One is there any evidence that growth hormone replacement can cause the residual tumor to grow?
No, this is something that people have asked a lot, and we've studied it quite a bit. And growth hormone replacement therapy does not cause the residual tumor to grow. It does not cause the formation of any new tumors as well.
And this one is a little bit more complex, but how does your approach change when you're evaluating a symptomatic patient with concurrent pituitary and autoimmune conditions that affect the endocrine gland? For example, a patient may have acromegaly and Hashimoto's thyroiditis, or they may have lupus and Cushing's. How does that affect how you replace the hormones if they become pan-hypopit?
Well, obviously, it becomes more complicated if you have more than one disease. But having, for example, acromegaly and Hashimoto's thyroiditis is a form, it's the most common form of hypothyroidism in the world. Up to 30% of women over the age of 65 will have it. It's what we call primary hypothyroidism. And usually we diagnose that by measuring the free T4 and the TSH levels. And we expect a high TSH and a low free T4. If you have acromegaly, however, and your pituitary isn't functioning properly, you may not have a high TSH, and then we rely on the free T4 level. And we try to keep that in the normal range, but we have to really interrogate the patient to make sure that they feel normal in regard to the thyroid function.
And I thought this question would be good for everyone in the audience to hear, but regarding estrogen replacement therapy, is there any difference between transdermal versus oral in terms of blood clot risk?
Well, there's one difference between oral and transdermal is both of them have risks for clots. To be honest, I don't know if one, depending on the dosing, the higher the dose, the greater the risk. So that one can mitigate that by going to lower doses. However, oral estrogen therapy causes the liver to become somewhat insensitive to growth hormone, so that patients who are on oral estrogen therapy often require very high doses of growth hormone to have normal growth hormone replacement therapy. And very often we'll switch those patients to a transdermal estrogen because those patients respond more normally to growth hormone.
Okay. So can you give any recommendations for patients that are in adrenal crisis and they show up in an ER and they're denied treatment?
Yeah.
Because it happens a lot.
Yes, this is very surprising to me that even patients who have medical alert bracelets sometimes can't get the therapy they need. So I usually recommend that they write on their bracelet, adrenal insufficiency, needs hydrocortisone. because that's the most direct thing I think you can say to somebody. That's why I think it's very important for patients to have injectable hydrocortisone at home, so that, or with them, carrying it around if you can, although that's not easy for a lot of people. But once you feel like you're in an adrenal crisis, an injection of 100 milligrams of Salicort will hold you over.
So I was at a meeting in Europe, and they suggest that the patients ask the hospital to write a statement that they're denying life-saving treatment. Will that change the mind?
Well, I think if you tell your physician that what you have, I've had several patients tell me they couldn't get the therapy, and it's usually the EMTs or the clerks checking them in. You can always threaten the hospital, I suppose, but I think that if you're adamant about it, if you bring in your medication with you to show the doctor that you have this, that helps.
So an endocrinologist told me recently that he had a patient at a pituitary center that was in adrenal crisis, and the ER made the husband go home and get the medication and bring it back to them. And that is shocking to me.
That is shocking, because every emergency room has Salicort.
Yes. And the dose wouldn't kill a person, where the patient going without that dose can.
Right. So, if you do have adrenal insufficiency and you think you're in an adrenal crisis, my recommendation is to take the Salicort. It's not going to hurt you. A single injection of it will have no bad side effects. Similarly, if you have a sick day and you're trying to decide, am I really that sick or not? I think if you're thinking about it at all that way, double your dose. It's safe to do it for a day or two, and then call your doctor and let them know that you've done that. Certainly, if the fever is over 100, 101, you should. Sometimes people, just don't know. And I've had patients, where they get sick very quickly, and those are the most dangerous situations. You get very sick, you go to sleep, you forget that you can't take your dose, you can't tell anybody what's going on. So it's important for the family members who live with the patient, obviously, to know about that.
And I always say too, for any patient who's just been newly diagnosed with adrenal insufficiency, not just the injectable hydrocortisone kit, but to have even like a letter that us from the doctor's office can provide to other physicians or other providers, just to say this person does have adrenal insufficiency, does require hydrocortisone. This is my office's number. Please call us if there's any questions.
Can you talk about growth hormone and its impact on sugar reading? Because I'm diabetic and I think I need growth hormone, but I'm concerned it's going to cause sugar to spike.
The question has to do with whether growth hormone can exacerbate diabetes or even cause diabetes. Growth hormone certainly can increase the blood sugar. In patients with diabetes, however, we can treat with growth hormone. We start with a very low dose, and we monitor the blood sugars. We may have to alter the diabetes medications to some extent, but we certainly wouldn't want to do it in such a way that we would raise the hemoglobin A1C in a bad way. So most patients with mild diabetes or well-controlled diabetes can certainly get growth hormone.
Oh, okay. We're out of time for questions, but what we do want to do is have everyone come up to the front to do a group photo with us if you'd like. There were some photo waiver forms that were out in the front, but if you haven't signed one yet and would like to be in the photo, it's okay. You can come up and then just sign it later. But yeah, so we'd like to all come up to the front and do a group photo with everybody. Everybody. Patients, everybody, family members.